Check your audio.
Good morning, everybody. Happy Monday. It's not quite April yet, but we're almost there. Spring-like weather's today. I think it's a high of 19 today, eventually. My name is Chris Moyes, and I'm the chair of the Board of Health. The clerk hasn't confirmed that we have quorum, so I'll call meeting 31 of the Board of Health to order. And again, welcome to those in the room and online. Today's meeting is being held by video conference and in person at City Hall in committee room number 1. Because we are meeting in person and remotely, we ask everyone for their patience with any delays and technical issues. If you are registered to speak at today's meeting, please listen for me to call your name. I will call speakers in the order they appear on the list. The list of speakers can be viewed online by visiting the Board of Health page at toronto.ca/council and clicking the speakers box for today's meeting. The clerk has provided all agenda materials on toronto.ca/council and via CMP, the clerk's meeting portal. Directors, please ensure that your video is turned on. Please keep your mic muted unless you wish to question staff or to speak on an item. As part of each agenda item, I will ask directors to raise their hand or unmute their mic if they wish to question staff or to speak. I will then create a speakers list and will call on directors when it is their turn to speak. When voting on an item or a motion, I ask that directors raise their hand to indicate their vote. Directors, I want to remind you that you must submit and approve your motion by email. Staff are available at boh@toronto.ca to help with motions. The Board of Health acknowledges that the land we are meeting on is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. The City of Toronto acknowledges all treaty peoples, including those who came here as settlers, as migrants either in this generation or in generations past, and those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. We pay tribute to those ancestors of African origin and descent. Are there any declarations of interest on the Municipal Conflict of Interest Act? If you have an interest, please raise your hand or unmute your mic and indicate the item number and the nature of the interest. Seeing none in the room or online. Next, we need a motion to confirm the minutes from our last Board of Health meeting on February 23rd, 2026. Director Chandrabalan, all those in favor? Opposed? Carried. Thank you. So again, good morning, everybody. Please join me in welcoming our newest Board of Health Directors, Rebecca Mador and Charna Gord. Did I pronounce that correctly? Okay, good. It's a good start. Rebecca Mador is a Métis citizen and the Director of Strategy and Planning at Shakab Makwa. An Indigenous-led Center for First Nations, Inuit, and Métis Wellness Innovation at the Center for Addictions and Mental Health. Her work focuses on health system planning, policy development, and building cross-sector partnerships to improve population health outcomes. Sharna Gord is a lifelong public health practitioner, educator, and advocate. She began her work at Toronto Public Health as the healthiest babies possible dietitian and eventually became the acting project coordinator of the Toronto Food Policy Council. She was also Associate Program Director and Lecturer in the University of Toronto Masters of Public Health Community Nutrition Program of the Della Lana School of Public Health. So thank you, Rebecca and Sharna, for joining us at the Board of Health. A round of applause, right? Sharna is online with us, and Rebecca is in the room with us. So we are very happy to have you, and I'm sure that your experience and expertise will shine as we continue this work together. As you may know, on March 26th, the AIDS Committee of Toronto closed its doors after serving communities impacted by HIV/AIDS for over 40 years. What started as a small grassroots organization in the 80s helped lay the groundwork for healthcare and policy landscape in which eliminating HIV/AIDS is within reach. They truly understood the people they served and what it meant to meet them where they were. ACT reached clients in what might seem an unlikely place to those outside of the community, bathhouses. For years, their team of dedicated volunteers assembled safe sex kits for distribution at the bathhouses in the village. I know that for many of the volunteers, the regular sessions provided a strong sense of community. This is the legacy that ACT leaves behind, one rooted in community, advocacy, and resilience. I would like to extend my sincere gratitude to the ACT team, past and present, for the unwavering dedication to supporting people impacted by AIDS. Now on to today's agenda. Our first presentation this morning is from Dr. Murdy herself, the 2025 Year in Review of Toronto Public Health. I know that Dr. Murdy really wanted to highlight the work TPH does every day to protect people from health risk and prevent illness before it starts through immunization, inspections, sexual health services, school health, food safety, health aging programs, and more. I'm looking forward to hearing more about these ongoing efforts and as well as some of our achievements from last year. Following the year in review, we'll have a presentation on our action to advance Indigenous health. At the core of this work are the principles of co-leadership and self-determination. Through the presentation, we'll learn more about how these are reflected in our actions. For example, the recent change to the way we allocate funding from the Toronto Indigenous Health Fund to the Toronto Aboriginal Support Services Council for distribution to Indigenous service providers, removing TPH as the intermediary. So thank you, Monique, for joining us to share updates on this work today. Our third and final presentation is on the health impacts of the homelessness and will include an update on the Downtown Core program. I've been closely involved in the implementation of the core team since the beginning, as their catchment falls in Toronto Centre, and I receive regular updates on their progress. I'm always amazed to hear about not only the volume of clients' interactions they handle, but also the meaningful impact they're making through sustained contact with the clients they serve. Recently, they were able to secure housing for 9 people, including 4 to be housed at our Heart Hub supportive housing in Toronto Centre. I really do believe in this model for outreach, and I'm happy to support the recommendations to extend the pilot another 18 months as the informal evaluation continues. And finally, on a much more solemn note, the province has doubled down on their shift away from harm reduction and overdose prevention by choosing to defund remaining safe consumption sites that receive provincial funding. In Toronto, this will impact the SCS at Fred Victor, as well as the Moss Park consumption and treatment services, leaving only the Kensington Market overdose prevention site and street health to serve the entire city. We've heard loud and clear from existing SCS and other community organizations that they have been overwhelmed since the first wave of closures. I've also heard from residents who have noticed a significant increase in public drug use. I can only imagine that losing more sites will compound these negative impacts. I'm also very concerned about the impacts further closures will have on our ability to collect information about the unregulated drug supply through Toronto Drug Checking Services. The trends we see in fatal and non-fatal overdoses are largely due to what is in the drug supply. If we lose sight of what is in the drug people are using, we will be ill-equipped to respond to overdoses. Naloxone is undoubtedly one of the most effective tools we have to reverse overdoses, but it does not reverse the effects of veterinary tranquilizers, which are showing up in over 80% of fentanyl samples. We wouldn't know this without Toronto's drug checking services. This is just one example of why we must ensure drug checking samples collection sites remain available. This board has historically been steadfast in its support for the life-saving and life-changing services provided by safe consumption sites. Beyond just the safe consumption sites, these sites offer breadth of services and supports that include low-barrier primary care, housing referrals, and mental health treatment. Today, I am bringing forth a motion that, in addition to requesting the province continue funding SCS, ask that if funding for safe consumption sites is cut, sites receive funding to continue providing these additional services for the clients they have fostered trusting relationships with. I am also commending that we add our voice to the public call for continued funding for SCS by signing the letter from the Canadian Drug Policy Coalition, Drug Strategy Network of Ontario, and HIV Legal Network urging the province to reconsider the decision to defund provincially funded supervised consumption sites in Ontario. I'll speak to the motion further when it is considered, but for now, I'd like to pass the floor to my new Vice Chair, Director Chandra Balan, to share a few words. Go ahead.
No worries. I'm truly honored to serve as the Vice Chair for Toronto Board of Health. I've had the privilege to be appointed to this board just over 3 years ago, and I'm proud of the progress we've made together. During this time, we've completed the recruitment of our Medical Officer of Health and launched our first post-COVID strategic plan work that I've both personally supported through the hiring committee and the implementation panel. I want to sincerely thank you, Chair Moyes, the outgoing Vice Chair, Councillor Bravo, and my fellow board members, but especially the dedicated staff at Toronto Public Health. Your expertise, your commitment, and ongoing support is what makes this work possible and meaningful. I look forward to continuing to serve on this board in this new role and continue to build on our progress as we make Toronto a better place to live, work, and play. Thank you.
Thank you, Vice Chair Chandra Balan. I'll now turn over to Dr. Murdy for her remarks.
Thank you, Chair Moyes and Vice Chair Chandra Balan. Good morning, everyone. It's nice to see you all here on this bright spring morning. Before we begin, I'd also like to extend my greetings to our two new board members. A very warm welcome to Charna Gord and Rebecca Mador. On behalf of Toronto Public Health, we look forward to working collaboratively with you, drawing on your diverse perspectives, shared expertise to address the evolving public health needs of our community. As we turn our attention towards today's agenda, I want to highlight a few pieces from our staff reports. First, we will be presenting Toronto Public Health's Year in Review for 2025. This report is just a snapshot of the diverse and impactful work that Toronto Public Health does every single day. As part of my requirement to submit an annual report, this report aims to highlight the range of activities that we do to protect, promote, and improve health. It also speaks to how we collaborate with partners, advance health equity, and use innovation to improve our services. You will see that the impressive statistics we present in this report were also achieved on a background of growing population, increasing demand for our services, and increasing complexity of the services we deliver. We're also highlighting today that our work with equity-deserving communities has been an integral focus of our work. In our Actions to Advance Indigenous Health report and in today's presentation, you will learn more about how Toronto Public Health is working with and within Indigenous communities to guide and co-develop an Indigenous wellness action plan for the city, strengthen our relationships with Indigenous service providers, and advance Indigenous health data sovereignty. Today, we will also focus on the health impacts of homelessness and receive an update on the Downtown Community Outreach Response and Engagement, or CORE program. We will be highlighting the range of actions and activities that Toronto Public Health leads, along with partners, to protect and promote the health of the people who are underhoused and homeless in the city. This includes programs like the Downtown Core Pilot with our Toronto Police Services and their outreach in the Downtown East community. I'd also like to acknowledge from Toronto Police Services the individuals who are here today and the collaboration that is having a positive impact in this community. The work we're doing with Toronto Torontonians who are at the intersection of homelessness, mental health challenges, and substance use continues to remain as important as ever. Since June of 2025, we have seen a reversal of the previous downward trends in non-fatal and fatal overdose calls to emergency services in the city, and with rising call volumes starting since June of 2025. This has more markedly increased since October of 2025 and is continuing to rise in 2026. This more recent change has been coinciding with an increasing frequency of tranquilizers detected in the drug supply, where now, as Councillor Moyes mentioned, over 80% of drug samples that were thought to be fentanyl are contaminated with medetomidine, an animal tranquilizer that is not approved for human use. The presence of tranquilizers means the effect of an overdose can last for several hours, and the effects of tranquilizers, unlike opioids, cannot be reversed with naloxone. These changing trends are just one more reason of why we remain committed to responding to the acute drug toxicity crisis. Foundational programs, monitoring, surveillance, reporting, public alerts, naloxone training, and drug checking services remain critical tools in our response to the rise in both opioid and non-opioid overdoses. These actions remain vital in our community when considering the provincial government's recent decision to end their funding for consumption and treatment services, including 2 sites in Toronto. Toronto Public Health and our community partners remain committed to supporting evidence-based approaches that improve health outcomes, save lives, reduce the spread of infectious diseases, and connect people to vital social and health services, including treatment, pathways to housing, and recovery. Finally, before I turn it back over to Chair Moyes, I want to recognize the work of Toronto Public Health's communications team, some of whom are in the room today. Our public health communications team plans and manages strategic communications, media relations, and the call center for Toronto Public Health. They play a critical role in ensuring that public health matters receive appropriate attention, understanding, and accurate information dissemination for Torontonians. I'm pleased to announce that this team has been named a finalist for the Strategic Communication Team of the Year category at the 2026 Strategic Global Awards. This awards program highlights outstanding achievements by communication professionals who are shaping the future of the field worldwide. Award recipients will be announced next month, and we are all keeping our fingers crossed for a winning result for our team. Finally, I'd like to say thank you to the entire Toronto Public Health team for your compassion and the commitment that you provide year-round. I'm proud to have this forum to appreciate and commend the contributions of everyone at Toronto Public Health. Back to you, back to Chair Moyes. Thank you.
Thank you, Dr. Murdy. Again, thank you to all our public health staff who do amazing work each and every day. So we'll move on to, we have 2 new business items to add here. So the first one is a letter from the clerks for the new appointments to the Board of Health, the 2 members. You want to post it online, on the screen? Thank you. Okay, I will move this item to be added to the agenda. All those in favor? Opposed? Carried. Thank you. And the second item is the letter I referenced earlier in my remarks, if you want to post that as well. Okay, I will move that. All those in favor? Opposed? Carried. Wonderful. Okay. So we'll do the rundown. So the first item is HL 31.1, 2025, a year in review of Toronto Public Health. There are speakers in their presentation on this item, so I will hold it down. Item 2, actions on advanced Indigenous health. There's a presentation on that item as well, and there is a speaker, so I'll hold that down. Item 3, health impacts of homelessness and update on the downtown core pilot. There's also a presentation on this item, and there's speakers as well, so I'll hold that down. Item 31.4, Toronto Public Health operating budget for the year ending on December 31st, 2025. Anybody wants to move that? Councillor Bravo, all those in favor? Opposed? Carried. T 31.5, Toronto Public Health capital budget for the year ending on December 31st, 2025. Director Madar, you want to move that? You want to move that item? Say yes. All those in favor? Opposed? Carried. Item 6, city approved Toronto Public Health 2026 operating budget. Director Gore, do you want to move that item? Yes, all those in favor? Opposed? Carried. T 31.7, city approved Toronto Public Health 2026 capital budget and 2027 to 2035 capital plan. Director Zhao, you want to move that item? All those in favor? Opposed? Carried. T 31.T, I don't know where I'm at now today. It's HL 31.8. Too many committees I sit on. 2025 performance appraisal, medical officer of health. Anybody want to speak to that item? Oh, we have a speaker on this item. Okay, so we'll hold it down. 31.9, reopening item HL 30.1 and HL 30.2 and HL 30.3 to correct appointments ending date. I will reopen that. All those in favor? Opposed? Carried. You want to post the new item? Okay, so just adopt it as a... Okay, we're going to adopt the recommendations as a whole. All those in favor? Opposed? Carried. Okay. Can I do 10? I have to hold it. Okay. HL 31.10, new appointments of the Board of Health. I'll move that item. All those in favor? Opposed? Carried. And there is one speaker on the new item, which is HL 31.11, Provincial Defunding of Consumption and Treatment Services. So I will hold that down. Okay. So we can go back to the top of the agenda, and I'm going to turn to Dr. Murray to speak to this item. 2025 year in review of Toronto Public Health.
Thank you, Chair Moyes. So we'll have the next slide. So good morning, and I'm very proud to be presenting to you today on our 2025 annual report. The 2025 Year in Review report represents a snapshot of Toronto Public Health accomplishments in 2025 to highlight a range of everyday activities as well as special achievements. I want to acknowledge that this is only a small portion of the work that TPH staff do every day. As the largest public health unit in the largest municipality in Canada, TPH helps more than 3 million people stay healthy and build a safe place to live, work, play, and study. As Toronto's population grows, so does the demand for public health services. We also recognize that people are facing a number of challenges to their health and well-being due to climate change, emerging infectious disease threats, the spread of mis- and disinformation, and a rising cost of living. Despite these pressures, in 2025, Toronto Public Health prioritized evidence-informed interventions, responded to health threats, and strengthened collaboration and partnerships in the community. Next slide. Public health is part of everyday life in Toronto, even when you don't see it. Every day, Toronto Public Health protects people from health risks and prevents illness before it starts through things like immunizations, inspections, school health, food safety, and healthy aging programs, and more. In 2025, we inspected more than 27,000 of your favorite restaurants and places to eat. We also provided education to event organizers for more than 1,000 major citywide events, making sure that residents and visitors can enjoy markets, festivals, and carnivals safely. Toronto Public Health also inspects businesses like nail and hair salons and tattoo parlors. In the last 10 years, we've seen a nearly 20% increase in these settings, which has put, and as well as an increasing complexity in services that has put pressure on our inspectors, who inspected more than 2,000 settings last year. The work of public health also extends to schools, keeping children and youth healthy across the city and helping them get access to nutritious food in school. In 2025, we provided school health services to more than 350,000 students across 815 schools, and we had the largest expansion of the student nutrition program that we've seen since 1998. Toronto Public Health also helps reduce the transmission of infectious diseases throughout our city. In 2025, we completed more than 1,200 investigations of vaccine-preventable diseases, infections such as measles, mumps, and pertussis, which is approximately double the pre-pandemic average of 611. Providing case and contact management reduces transmission risk and protects residents across the city. These investigations are increasingly complex as Toronto Public Health has seen an increase in the number of clients experiencing homelessness, individuals without access to primary care, and newcomers navigating the healthcare system. We also responded to 318 active tuberculosis cases, an increase of nearly 25% in the last 10 years, providing critical case management and prevention efforts that help provide supports for people infected with TB and reduce transmission risk, including in settings such as shelters and schools. In 2025, we also managed the local impact of 2 province-wide shortages of rabies vaccine that require timely modification to guidance to health professionals to ensure that individuals with potential exposures to rabies were adequately protected. These shortages were compounded by a 28% increase in rabies exposure assessments compared to the year before. TPH plays an important role in responding to emerging population health concerns. In 2025, we responded to the largest Ontario measles outbreak in more than 25 years, with case and contact management, health promotion messaging, and vaccination through TPH programs and public education campaigns, helping limit the transmission and protect residents. Efforts to respond and maintain vaccine coverage resulted in only 10 measles cases locally in Toronto, compared to the over 2,000 cases provincially, and only 2 of those cases were linked to the larger provincial outbreak. In response to record-breaking heat events in the summer, we worked with partners to continue increasing the number of cool spaces to more than 550 publicly available locations, monitoring heat-related illness, and continuing to develop heat vulnerability mapping to identify communities most at risk. In 2025, Toronto Public Health supported the response for 4 Northern First Nation communities that were evacuated to Toronto due to wildfires. This included a number of our services, such as immunization, dental screenings, harm reduction, breastfeeding, and parenting supports. We also had our Indigenous health team on site supporting the facilitation of communication and culturally safe care. Finally, our team responded to 475 media requests on topics such as respiratory illness, measles, extreme weather, and rabies throughout the year, helping residents make informed decisions to keep themselves and their loved ones safe. Toronto Public Health collaborates with other city divisions, hospitals, clinics, pharmacies, and community partners to develop and implement public policy and programs that enhance the health of individuals, communities, and the entire city. Working within the continuum of healthcare and within community agencies helps ensure residents are more connected to services and care reaches those who need it most. Some highlights include that in 2025, one of our largest accomplishments was the establishment of the Downtown Toronto Homelessness and Addiction Recovery Treatment, or HART Hub. Toronto Public Health worked with the Ontario Ministry of Health, Ontario Health, city divisions, and health and community partners to propose, establish, and execute funding for the HART Hub, which is providing substance use care and housing. We also increased access to breastfeeding services through expanded hours and the opening of 2 new breastfeeding clinics in partnership with Humber River Hospital and Ancestral Hands, increasing access to care and increasing parent knowledge and skills to support successful breastfeeding in equity-deserving communities. To support pregnant people and new parents, we also expanded access to in-person support groups through the Perinatal Adjustment Program in partnership with South Riverdale Community Health Center and Match Midwives. Finally, in 2025, we relaunched the Your Health Matters partnership with Toronto Public Library, offering people recommended resources on nutrition, sexual health, physical health, and mental health, easily accessible to residents in their own local library. The collaboration is a focused collection of adult and teen books available at 19 branches across the city, aimed at supporting physical and mental health, reinforcing Toronto Public Health as a trusted source of health information. Another important role of Toronto Public Health is monitoring health trends, using evidence to guide decisions, and advocating for policies that keep people safe. In 2025, I provided witness testimony to the Senate Standing Committee on Social Affairs, Science and Technology in support of Bill S-202, which would require warning labels on alcoholic beverages about risks such as fatal cancers. Our team also submitted recommendations to Health Canada's 3rd legislative review of the Tobacco and Vaping Products Act, emphasizing the importance of enhanced enforcement and compliance, restrictions in online sales, advertising, and retail availability. Finally, we regularly support our city divisional colleagues with evidence and advice on a number of topics, including, but not limited to, indoor temperature, noise, safe TO, the health of seniors, and suicide prevention. As public health experiences ongoing growth in both demand for and complexity of services, we need to find ways to innovate and modernize the way we work to continue to meet our mandate. Some examples of innovation in 2025 include transitioning our DineSafe system to Salesforce, replacing the outdated system which will streamline food safety inspections and investigations, launching an online system for Toronto doctors, nurses, and hospital pharmacists to order publicly funded medications for the treatment of sexually transmitted infections, reducing administrative workload for staff, as we've been seeing an increase in both STI rates and orders for medications in Toronto. Enhancing our technology to manage tuberculosis cases without an increase in case managers. This includes an immigration medical surveillance tool to streamline medical reporting for those entering Canada and required to complete an immigration medical exam. Finally, piloting new tools on a small scale, such as electronic consent, that lets parents consent to vaccine clinics without having to fill out, track, and process paper-based forms for routine immunizations in schools. At Toronto Public Health, we strive to create a healthy city for all. We do this by responding to threats to health, meeting community public health needs, complying with the Ontario Public Health Standards, and evolving to meet the needs of a growing city. Together, our efforts promote health, reduce gaps between communities, strengthen emergency readiness, help people stay healthy, and build a safe place to live. I'm proud of the dedication of all staff to deliver these critical programs and services each year. Thank you.
Thank you, Dr. Murdy. We do have speakers on this item. Up first is Daniel Freiheit. He's usually online. Daniel, are you there? Sure, my timer is working properly. Daniel, can you unmute yourself? We'll get back to him. Let's try Gil Panalosa. Is he there? Yeah. Brooke Coatsworth.
Oh, there we go. How's it going? Oh, looks like it's wrong video there. See if that helps. Great. Thank you. Thanks for your patience. I had sent in a presentation. I'm not sure if...
sorry, Daniel Freiheit. Go ahead. Go ahead.
Hi there. I'm not sure if my presentation was able to get through to the secretary for for viewing. Are you able to confirm if that was received or can be displayed?
One moment. You're able to share your presentation, Daniel.
Okay, great. I'll do that.
There it is. Okay.
There, yeah. So just by way of an introduction to the new members of the board, first of all, welcome. I'm you can call me the Jiminy Cricket of the Toronto Board of Health. I at one point applied, but now I'm just kind of an outside advisor, consider myself. So what I'm showing here, I just wanted to speak to so I do a lot of advocacy on X, by the way, about, talk about this misinformation and disinformation, words that were used, by the way, in this report without really explaining what it is, what it was, and how the board plans on tackling it. So I kind of do this in my own way by just kind of always going to my authorities and source documents. What you're showing here, what I wanted to bring to the board's attention here is part of the vaccine injury reporting mechanism that the Board of Health had used during COVID. This is an individual who had contacted me. Oh, did it go away? Yeah, there it is. So what you're seeing here, and I just want to bring this to the board's attention, this is an adverse event document, a reporting document that Toronto Board of Health, Public Health had used during COVID. The left side, these documents should be the same, but they're not. They're actually, and I highlighted it on the right, the difference between these two documents. This is a document of an adverse event following immunization. One copy on the left was sent to the patient. The other copy on the right was sent to the patient's doctor. And the reason why this is important is because what this shows is that an adverse event investigator within Toronto Public Health was sending misleading or different versions of the same document and kind of representing that they were the same. In one case on the left, the investigator tells the patient that the adverse event was likely caused by the vaccine. On the right, it says it was possibly a psychological reaction, and that version was sent to the patient's doctor. And so when we talk about misinformation and disinformation, the board needs to reevaluate their own, kind of do a retroactive evaluation as part of its future planning for addressing misinformation. What we're seeing here is that in this case, it resulted in the patient having delayed medical treatment because the doctor who got this contradictory or got this misleading report ended up not properly treating the patient. Toronto Public Health during COVID, and even now, it still acts basically as a patient's physician. Like, even though it's not really supposed to, it effectively does. So it has to be really careful and do a proper investigation into what happened here with these adverse event reports and the investigator in particular. How's my time, by the way? Where am I? I don't even see my time anymore.
You have 2 minutes left.
Okay, I'll be fast because I see there's other speakers too. But basically, and Councillor Perusa at one point, I talked about a cover-up in one of my previous delegations. Maybe that language is a bit harsh, but something like this is, it's pretty close to, to something of that nature. When you have these investigation reports that are misleading patients as to what has been sent to their own physicians. It took this particular patient almost 2 years to discover this. As you scroll down, what I tried to do through an Access to Information Act request is find out how common this was. Like, what was the practice here of, sending of the adverse event reporting mechanism, and was there self-correction going on within Toronto Public Health to fix this problem? Whether it was just a rogue investigator or whether it was a practice to send different versions of adverse events to the patient and different versions to their physician. And I was roadblocked on this request because I was told here, so I asked for whether there were any changes to the internal adverse event reporting procedures in response to identified or alleged mismanagement. So maybe I could narrow that down and just say, what was the adverse event review protocol? Because I think this was an example of, I'll call it insidious misinformation, because it was done behind the back of the patient. But you can see in that response, the city or the board refused to provide any response to that request because it was considered meetings, consultations. So I could fight this information request. It'll probably take me 4 years to make any progress.
You have 10 seconds, Daniel.
Yeah, so if the board wants to, take any steps to address this as part of its misinformation, disinformation campaign, that would be amazing.
Okay, thank you. Any questions for the deputant? Seeing none, thank you.
Thank you.
Is Gil Panasola here? No, still not here. Brooke Coatsworth, online. Brooke? Can you hear me? I can see you. Unmute your mic, please. I can see your name. Brooke Coatsworth?
Yes, good morning.
Here we go. Okay, 5 minutes, go ahead.
Thank you very much.
Go ahead.
I'd like to start this year in review by reflecting and remembering that every word spoken in this chamber, every light bulb and every salary paid, including those city councillors, is funded almost entirely by the hard work and earnings of taxpayers and property owners. Nearly all of the city's $18.9 billion budget comes directly from them. We acknowledge that while taxpayers and property owners have endured an almost 20% increase in the last 3 years, only a small and insulated group decides how much of their income is expropriated to sustain a burgeoning municipal bureaucracy that continues to grow regardless of outcomes and results. We pay respect to those taxpayers because without them, this institution could not
Can you
indulge
focus
in
on
ideological...
perhaps the item in front of you? I'm not quite sure you're talking about.
I am, Councillor. Thank you very much.
Year in review for Toronto Public Health.
Yes, and I would like to acknowledge the taxpayers that have supported the year that you guys are reviewing. Thank you. In the spirit of acknowledgement and Councillor Moise's urgency, and with an eye to the future, we recognize the Toronto taxpayer and revere their tolerance for being taxed. Yes, I am here to speak to HL 31.1, a year in review. Year in review speaks to a year of progress as we move forward into the new year. I have to say, after a few TPH board meetings last year, it's great to see so many councillors in the chamber today. To make it out for the first TPH board meeting under the new year and new and former chair. Also great to see that the meeting only started 4 minutes late today. Pretty good. Toronto Board of Health oversees public health policy and programs for the city. Over the past 40 years, it has led several impactful initiatives, including the expansion of smoke-free bylaws. It's strengthened school immunization enforcement programs, the introduction of Dine Safe system, and many other programs that are measurable, sustainable, and that have contributed to the improvements in population health across Toronto. Now, your focus on infectious disease, the drug toxicity crisis, cost of living pressures, climate risk, and misinformation, all wicked and complex problems. As you move forward, I want to first remind you that public trust is shaped by what people see and experience. Since Councillor Moise took the chair role, in 2022, TPH has reset its strategy with a heavy focus on community-based and equity-driven approaches. This is a focus on how public health operates, not just what it delivers. As you move forward under the same leadership, I must remind you, the TPH board, that there is considerable evidence that Councillor Moise does not operate in the public's interest and has a political activist motivations. For example, having a public board member from a professional lobby and political strategy group as his new vice chair raises an eyebrow. For all those board members still listening, keep in mind that the citizens of Toronto are paying more attention than we were in 2022. Thank you very much.
Okay, any questions for this deputant? Seeing none, thank you for your time today. Up next is Norad Bouzidi. Not here. Norad, not here. Okay. Arnold Marguilis, online. Arnold, I see your name on the screen. So mute yourself. Arnold? Can you hear me, Arnold? Okay, we'll come back to Arnold. Daniel Tate, are you here? Okay, five minutes.
Good morning. I'd like to quickly start with the civility acknowledgement. As we gather in this hallowed civic institution, we remind ourselves to speak with care and to refrain from derogatory or hurtful remarks. The prestigious office of local government and the people it serves demands the highest standard of conduct, and we reaffirm our commitment as political leaders to engage with constituents in an honorable and respectful manner.
Can you speak to the item in front
Now,
of you?
on to the year in review for Toronto Public Health. I just want to remind this room and everybody watching that the budget for this division is $307 million in fiscal 2026, with $13 million allocated for harm reduction activities. Just to do a recap of some 2025 statistics, in 2025, Toronto Public Health distributed 1,799,272 needles, many used for intravenous fentanyl injection. 943 smoking pipes used for the inhalation of fentanyl and crystal meth, and 579,668 crack pipes for crack smoking. Many in the community wonder if we'll break the 2 million mark for needles in 2026. I guess we'll have to stay tuned to find out. Now, obviously, the chair and the medical officer are ecstatic about these numbers, as evidenced during their budget meeting, in which both discussed the need to add harm reduction distribution capacity. Now, on the topic of harm reduction, with all these harm reduction supplies that have been distributed, I think it would be very wise to show these supplies in action on the streets of Toronto. Here we see this individual using their city-issued meth pipe, enjoying his pastime of meth smoking on the TTC. Another individual with their city-issued crack pipe, smoking it also in the TTC in full view of citizens and their children. Here we have somebody in the throes of fentanyl addiction on a GO train. Very likely they use city-issued supplies as well. Here we have the city-issued harm reduction kits strewn on the ground in Yorkville, about 30 meters or so from a public playground. We can see tourniquets, needles, etc. And then finally, we have another individual in the throes of crystal meth addiction, participating in this activity on the subway in full view of subway passengers, also using his city-issued, taxpayer-funded pipe. So everybody in this room calls what I've just displayed harm reduction, but a very large majority of citizens of Toronto call it harm production. Now, with regards to the annual report from the Medical Officer of Health, I noticed a few omissions, and I'd like to speak on those quickly. The first is the decline of olfactory health. What is olfactory health? Well, it's the nose. It's what we smell. And right now, a lot of people say the city stinks. Take a walk on the streets of Toronto. You will smell disgusting trash fumes emanating from our garbage bins that are busted. You'll smell the remnants of public defecation and even sewage in some places. Why is there no discussion of olfactory health? Because we know that is an important thing for public health. The scourge of public defecation is real, and there's no mention of it also in this annual report. What is Toronto Public Health doing to mitigate the scourge of public defecation? I just came back from Spain, and they have a wonderful network of public bathrooms. Their streets are spotless. Why do we not have that here? Also, the word detox or rehab appear exactly 0 times in this report. Why? Lastly, the words mental health are also missing from this report. And when we're talking about the impacts of mental health, we're not just talking about the mental health of drug abusers, but we're also talking about the mental health of law-abiding regular citizens and their children who have to witness the behaviors of these drug abusers. What about their mental health? In summary, this report leaves a lot to be desired. There are severe pressing issues that seem to have been glossed over, and taxpayers are wondering if we're getting value for our $307 million. Thank you.
Okay, any questions for this deputant? Seeing none, thank you. Nicole Kuroda. Is Nicole here? Welcome, Nicole. Nicole? Okay, let's go to Mariko Uda, or Ude. Sorry, Nicole. Okay, Nicole's there. Nicole, can you hear me?
Yes, I can hear you.
Here we go.
Finally, I'm able to start I'm able to start to unmute. I
Okay,
couldn't unmute.
we can
Sorry
hear
about
you
that.
now. Go ahead. You have 5 minutes. Go ahead.
Yeah. Okay, so a couple of things. Um, it- a few things. I think that it's very obvious that from this report that animal health is connected to human health. A rabies vaccine shortage is not an excuse to kill and dissect animals. The solution is obvious: more rabies vaccines and better humane testing. Well, antemortem test is only currently allowed for humans in Canada. The vaccines can be used without testing the animals as a precaution.
Nicole,
Testing
the
brain
issue,
tissue.
Nicole, we're talking about the year in review for public
Yes.
health, not about
Yes, I
animal
know.
testing. So can you please try and stay on topic?
Yes, this is part of the topic. What I was saying is that it is in regard to the rabies exposures. It says testing brain tissue needlessly kills orphans and mutilates animals. Many animals who bite are mothers, and it also causes dangerous false negatives. If the animal who bit only had rabies in their saliva but not their brain yet, then a brain test would come back a false negative. There are fortunately point of care tests like the Dine Immune rapid rabies test by Dr. Michael Huchitel that can test, say, even can swab a bite, saliva from a bite, because you can tell which animal from DNA testing, which animal bit a person from a swab of a bite. You could test rabies the same way, and I think the City of Toronto needs to look into that. The other thing, safe dining is also a human-animal coexistence issue. A lot of food waste attracts rodents, raccoons, coyotes, bears, etc. But the poison bait and glue traps are both cruel and attract a lot more animals, weakening them and making them prone to disease. Please ban cruel methods of rodent control and work with Rodenticide Free Ontario, an organization dedicated to ending glue traps, poisons, and other lethal forms of rodent and wildlife management. A nutrition program is best served as plant-based. Animal agriculture is a breeding ground for zoonotic illness, diabetes, heart conditions, etc. Humans are designed to eat plants. It's better for humans, animals, and the planet. All universal nutrition programs need to be vegan, because that's a universally designed, everybody can eat vegan food. And so I think more looking at human and animal health as one health, and but not looking at the animals as vermin or as things to eat or as a health threat, but looking at humans and animals as neighbors and as part of the same family, looking at it holistically and ecologically. That does tie into the this item, because these issues are in this item if you look very closely. I think tax dollars, other people were saying we have to be thinking about how our tax dollars are being used. The most efficient way to use the tax dollars is to look at things ecologically, to instead of just putting money into harm reduction, actually put money into the root causes of the addictions. Look at, why are these people being addicted? Well, maybe they don't have proper housing. They don't know, when their next meal is coming. So all that anxiety is keeping their addiction going. But if you got rid of the root cause of the addiction, you would end up getting rid of the addiction altogether. So looking at how animals are getting into waste bins, one prior deputant said that animals are getting into waste bins. Well, if you secured the bins, say with bear boxes, the animals would not be getting into the bins, and then you wouldn't have these bite incidents. If you got rid of the poison bait boxes that are used for rodenticide, which attract other animals, you would have less bite incidents. So that's looking at keeping the animals healthy, keeping the environment healthy, and providing healthy, vegan, plant-based food for people, and
Okay, final
providing.
thoughts, Nicole. You're almost at time.
Final thought is look at everything holistically and from an
Okay,
ecological
thank you very much.
perspective.
Thank you. Any questions for the deputant? Seeing none. Thank you. Arnold Margulis. Yeah, here we go. I could see you. Just unmute yourself, Arnold.
Do you hear me?
Yeah, we can hear you now. Go ahead, 5 minutes.
Excellent. During this year, we heard a lot of presentations at this board talking about indoor air quality. Not much was said today, by the way, but I wanted to amend the presentation. So some landlords, surprisingly, not only schools, but also the rental housing, they use intentionally pollute indoor air quality in order to speed up tenants turning around in the building, or if it's a public housing, to receive renovation funds from the city. This is true. And my attempts, for example, in my unit, this is exactly the case. I don't want to name my landlord, but not only in my unit, but also in the building hallways, through the ventilation system, the air is regularly at night intentionally polluted. And some landlord cronies are approached to also contaminate air from their unit, contaminate air in the hallways. So obviously I discussed it with public health several times, and unfortunately their attitude and their equipment is inadequate to address this particular problem. For example, they regularly came or periodically came to my unit with 3 to 4, 5 hour late based compared to previous arrangement. They don't have night shift where the landlord usually undertakes this activity. And the equipment like portable air quality meters, they are inadequate. For example, they don't measure TVO, total volatile organic compounds, in the air. And the landlord namely contaminates using volatile organic compounds such as insecticides, highly potent poisons, and very strong industrial cleaners and similar things. So, and instead, they practically show me like presence of the particulate matter in the air, which is totally irrelevant to these particular measurements. So basically trying to fool the complainant or city resident. So the reports also don't refer to particular regulations of Canada or Ontario, and they don't refer to particular equipment model intentionally because the equipment, as I said, is inadequate. The other thing is that the low training level of the inspectors who are coming, and even the managers of particular areas or particular areas of the city, they are not familiar with building design, HVAC equipment design, and they don't know how to, for example, they don't understand explanations of tenants like myself. I'm a professional, how exactly landlord intentionally contaminates the buildings through ventilation system and through other systems. So the other thing is that the province has equipment loan program, and in particular, they can easily loan for free. For example, volatile organic compounds meters or some tubes to collect overnight, and then use the mass spectrometer to have the specter of contaminants present. They don't know about it, despite the medical officer of health came as understand from the province. So the other thing is that access to Ontario labs, they also have access that they don't use. And for example, behavior of some staff, like associate directors, apparently they are kind of assigned for life. Like Mrs. Anna Miranda, shut down voicemail, shut down telephone, never respond to emails, so she doesn't exist. And it's not even clear where she sits. Impossible to make an appointment. Now, night shift is mandatory, at least one public health inspector at night to ensure indoor air quality in public places and in residential buildings. Now it's none. After 4 p.m., they never come. And this is totally inappropriate. I'm asking the Board of Health, first, the associate director should report every 6 months to the Board of Health their accomplishments. Second, establish night shift.
You're at time. You're at time.
Thank you.
Thank you for your deputation. Any questions for the deputant? Seeing none, thank you. And last on my list is Mariko Ude. Did I pronounce that properly? Is it Uda or Ude?
Yeah.
Uda, okay.
Yeah, thanks.
5 minutes, go ahead.
Okay. Good morning. So in the Toronto Public Health 2025 year in review, it does mention immunization, but there were just 2 bullets. And I would have liked to seen a bit more detail on the status of COVID-19 vaccine administration. I think it's significant to include this in the report. When I go to the Toronto Public website, public health website, it says that COVID vaccines are available now for everyone 6 months of age and older, and that TPH is hosting community clinics for young children 6 months to 4-year-olds by appointment. I'm interested to know if that actually happened. If so, I'm surprised because according to the National Advisory Committee on Immunization, which Toronto Public Health follows, they do not strongly recommend vaccinations for 6 months to 4-year-olds. They use the word may, not should, and it's just one word, but it's so important because and it's confusing because NACI has 2 kinds of recommendations. One is a strong recommendation, and in that case, they use the word should. And then the other recommendation is a discretionary recommendation, and they use the word may. And a discretionary recommendation really, in my mind, should not be called a recommendation because, well, I'll read you the definition of a discretionary recommendation. NACI says known or anticipated advantages are closely balanced with known anticipated disadvantages or the uncertainty in the evidence of advantages and disadvantages exists. So it's very, it's not a confident recommendation at all. And I think they shouldn't call it a recommendation. But they do, and then that's why I think it gets misunderstood. And then Toronto Public Health on their website says that infants 6 months to 4 years should get vaccinated once a year. But I think that should be changed to may, because we have to follow the National Advisory Committee of Immunization at least. Like, we can't go beyond unless, because we don't really have that expertise, or I can't think of the word, but like we should be following National Advisory Committee on Immunization. And I'm happy to, talk about it more. And this is all very concerning because as time goes on, more and more evidence is coming about the side effects of the COVID-19 vaccine. So why would we give it to our most vulnerable babies? Last year, over 80 researchers and clinicians penned a Canadian open letter calling for the halt to the mRNA COVID vaccines. And in other countries, they are not giving it to the young and healthy. For instance, Sweden, they don't give it to anyone young and healthy. And as well, Japan, like you have to pay in Japan to get the vaccine, about $100 if you're younger than 60 and young and healthy. So in closing, I would like the extent of COVID vaccinations to be documented in the year in review 2025, and also that all COVID-19 mRNA vaccine recommendations be reviewed considering the concerns in this call to halt letter, which can be found at www.call halt19.ca. And they highlight like 5 emerging concerns that we may have not known at the very start of the COVID-19 vaccine campaign, which I think are very important to look at. And in particular, I would like the recommendation to vaccinate infants to be reviewed and immediately addressed for the love of our children. Thank you very much.
Yeah, thank you. Any questions, Deputant? Seeing none, thank you. There is one more, I know, there's one more speaker that was just added, Skylar Hill-Jackson.
May I have the overhead, please?
Just put it on the screen, it should come up, I think.
This deputation is asking board members, do not believe everything you think. I understand the Toronto Board of Health 2025 year in review is committed to making Toronto a healthy and resilient place for all by following best practice guidelines and optimizing health outcomes at all levels. I see Toronto Public Health literature states vaccinations keep your children healthy. I ask why our Toronto children currently are the sickest generation. Toronto children are experiencing a major epidemic of neurological and immune system disorders requiring EpiPens, nut-free zones, and special ed teachers. Are the 75 doses of 18 vaccines recommended by Toronto Public Health really protecting our children's health? Vaccines have never been safety studied, and there are no studies on the safety of combining multiple vaccines. Are there too many vaccines? In 2004, Ontario added the chickenpox vaccine, and now there is a shingles issue in the older population. But no worries, there is a shingles vaccine for seniors. If you mess with nature, there will be consequences. Why is Toronto Public Health afraid of childhood natural illnesses? What happened to trusting our natural immune systems? Currently, women are choosing not to take the recommended 7+ vaccines during pregnancy. Today, educated women know that everything crosses the placenta and the blood-brain barrier, and vaccine ingredients may damage the unborn baby's brain, just like alcohol, drugs, and smoking. These educated women know there are no safety studies to support pregnancy vaccinations. And now parents are questioning the safety of recommended childhood vaccines. There are 30,000 Toronto district schools, grades 2 to 5, elementary school children who are eligible for school suspension notices. Is this because many parents are realizing the harms that vaccines may cause to their children? Pregnant women and new parents are afraid of vaccine roulette. They are afraid of vaccine roulette because apparently no one knows the real cause of autism. Maybe it is genetics, maybe it is the improved modern autistic diagnosis methods. It basically remains a mystery. Instead of getting hysterical over 10 measles cases in Toronto in 2025, why has the Toronto Board of Health ignored the real epidemic in Ontario? As of early 2026, over 84,000 children are registered in the Ontario Autism Program and seeking services. Reports indicate over 60,000 children are waiting for care. April is World Autism Awareness Month. Our public libraries call April Autism Awareness Acceptance Month. Autism is being normalized in Toronto classrooms. Autism is not normal. What is the board's plan for who will look after all these autistic children when they become adults and their parents die? Why is Toronto Board of Health ignoring the autism epidemic? Nothing in this deputation is misinformation, disinformation, or malinformation. The science is never settled. The greatest obstacle to discovery is not ignorance, it is the illusion of knowledge. Toronto Board of Health members, do not believe everything you think. Thank you.
Okay, thank you. Any questions for the deputant? Seeing none, thank you. Okay, we'll now take it in-house. Any questions for staff from board members? Dr. Zhao, go ahead. Dr. Zhao.
So thank you, Dr. Murdy, for a very comprehensive presentation. And I really like the dashboard that you've put together on keeping us updated on all of the different initiatives, from providing vaccination updates to members of the public, information about misinformation, for instance, as well as the targets around the harm reduction and heart hub models as well. My question is more around harm reduction leading to treatment. So I recognize that there's been a lot of discussion on providing harm reduction supplies in the dashboard. However, I also recognize that the Board of Toronto Public Health does a lot of work when it comes to opioid agonist therapy, providing treatment to people who use substances. And I was wondering if you can sort of highlight that a little bit more for the board, as I didn't notice it was covered very comprehensively in the dashboard.
To the chair, thank you for the question. This was meant to be a snapshot, so we weren't able to fully include all of the aspects of it. We thought we would choose a few pieces that were not necessarily highlighted in either the strategic plan or other regular updates, like we had at the Our Health, Our City annual update that speaks a bit more fulsomely to some of the questions you have on mental health and harm reduction. So certainly I think we highlighted the rollout of the Heart Hub as our key achievement, or one of the key achievements in 2025, having to transition from the closure of our supervised consumption site to the addiction and homelessness treatment model. And so we are very proud of the work that's been able to have almost no days lost in terms of the opioid agonist therapy. So we closed one day and the next site was open immediately the next day. So the clients that we were seeing for treatment on opioid agonist therapy could be transitioned immediately to the new site, and have been able to continue with that, with the treatment of those clients through this year. We have certainly had some challenge this year with the ending of the injectable opioid agonist therapy by Health Canada by the end of 2025. And we have seen some loss of clients who preferred that method of therapy as treatment compared to what we were able to offer now without that option. So we are continuing to work with our partners. I think, one of the biggest things we're still transitioning in this new model is how to have more clients aware about coming into these services. So I think it speaks to what Chair Moy spoke about in terms of the need for some of the drop-in services that can really be that friendly front door for people who are using substances, who, when they are ready for treatment, can be referred to treatment options. And we have a less of that front door, and we're losing more of those front doors with the closure of these sites. So I think having that ability for people in the community who are interacting with these clients to know about our service, to make that kind of warm handover to our services when people are ready to experience treatment is definitely something we continue to work with all of our outreach partners on, as well as the community partners. But certainly it's a challenge with more of those friendly front doors closing their spaces.
Thank you. And I also wanted to highlight that a lot of the people who come to you for harm reduction are often offered treatment, primary care, and it seems like that's also a very positive impact that Toronto Public Health is having on a lot of people who use substances as well.
To the chair, yes, we're absolutely, I think that we'll see in the next presentation, I think some more of the highlights of just one of our outreach programs where when we are able to interact with clients and really assess, what kinds of needs they have, provide that case management, able to link to social services and other supports. Housing is absolutely one of the very common issues that people are identifying as a need to address. We work very closely with our Toronto Sheltered Services partners, as well as the other outreach team, the Toronto Crisis Communication Center as well, to make sure we're connecting and really trying to be as coordinated as possible to find the right route to housing, to supportive housing that's necessary for that client. I think we're very welcoming of the 25 units that we have through the Heart Hub model, and that we're able to now identify clients who can enter housing through that pathway as well.
Thank you for your statement, and I would be very interested to hear in the future how many of those clients are moving from, let's say, harm reduction or being offered treatment and wraparound supports as well.
Wonderful, thank you. Any other questions from Councillor Bravo? Go ahead. Sorry, Director Uzude, you had a question? Go ahead, 5 minutes.
I did. Can you hear me?
Yes, we can.
Beautiful. First, I want to start by saying welcome to our new board members, Charna and Rebecca. Thank you for applying, and we're looking forward to working together and bringing all your expertise. And I want to say thank you to Dr. Murty and the staff of Public Health for this wonderful report. My question is more on, so we've done a good job, 2025, but there's always rooms for improvement going forward. I read through the report, but I couldn't find this. So I'm just curious, are there any like 2 or 3 top priorities between the capacity that TPH has now and the need in the community? And if so, do we have any plans to address that going forward for this year?
To the chair, thank you for the question. So the goal of this report was not necessarily to identify those areas for improvement. We do still, this was meant to be an adjunct and kind of a snapshot in time to our larger updates that we do to our strategic plan. So very much we are still looking at fulfilling some of the outstanding areas of the 2024 to 2028 strategic plan as kind of our continued priority areas that we're moving on and forward onto those areas to really keep focused as to what are those specific, biggest picture health issues in the city that we're trying to address. I think within the report itself, we'd have really tried to highlight that we are providing these services on a backdrop of a growing population, growing demand for a service, and growing complexity of our services. I think just a couple of examples to that to really highlight within the report we showed is that our personal service setting inspection time has gone from 30 minutes to 55 minutes. And that's a change because of the complexity of services that people are providing in these settings. We're going into places where we're finding non-regulated healthcare, just people who are not healthcare providers offering Botox, offering microneedling, so very complicated investigations that our investigators have to go in, assess what's actually being provided, assess the risk of that. Is there any need for notification? And we're seeing many more of these places than we have in the past. So the volume of settings is increasing because we know that these services are becoming more popular, but also the complexity is increasing. So we have, we'll definitely have already started to experience an inability to get to every single site that we would like to, but we also need to look at new ways of really classifying risk and making sure we're getting to those highest risk sites to address potential risk within the community. Just one other example to that, I think, is the complexity we have in terms of people navigating services. So for many of the infectious diseases we have, it's very challenging to find a primary care provider to be able to actually do some of the testing and follow-up that's necessary as part of that infectious disease investigation. This year, we had earlier in 2025 and as well now towards the end of 2025, outbreaks of Shigella infection, which is a diarrheal illness in the homeless population. And finding the right pathways to care for these individuals is quite complex. And so there's not just the case and contact management public health aspect, but also the complexity of navigating a healthcare system when one's not really available for these clients.
Thank you for that. And then just one quick follow-up. We had a favorable variance, which we're going to see later in the agenda, of favorable net variance of about 15 million. And I'm just curious, how should we interpret these achievements alongside the variance/underspending, especially in the areas of high need?
To the chair, thank you for that question. We had a variance because of a shift of staffing that we had. So we've had a very major reset in terms of particularly a lot of our nursing staffing in terms of the work that we were doing pre-COVID and now adapting to the new Ontario public health standards in terms of healthy aging across the lifespan. We will not be seeing that same variance coming forward in 2026. We have had a number of hires coming in, both at the end of 2025 and now continuing in 2026. So we are much closer to that full staffing level that will bring that variance down for this year.
Okay, thank you.
Thank you. Any Councillor Bravo?
Thank you. So I have about 5 questions. I'll try to do this quickly. In terms of drug testing, in the past we've heard from staff here that it's not quite good enough to offer, but is this an important line of defense when drug users who may live in be very wealthy in a nice home, all the way down to somebody who's living on the street, a way to self-protect in terms of being able to test their own drugs and take agency over their own health?
Yes, to the chair, absolutely. We do really rely on the drug testing program. I believe Councillor Moise has a motion to this later on in terms of the importance of this service. And that's the only reason we know that 80% of the supply is contaminated with things like animal tranquilizers.
And that cuts across every part of society. Because drug use is pretty universal. Thanks. So the next one is around opioid treatment. What is available right now? What does that look like in a nutshell? And do we have enough of it?
To the chair, what we're providing in our 117, the Esplanade site, is largely the oral opioid agonist therapy. We do have some other adjunctive therapies for people depending on the complexity of their condition. So certainly within the broader treatment system, I'm sure Dr. Zhao could maybe speak to even sort of what else is there in the broader community as well. But the types of pathways from detox to longer term therapies to more conventional cognitive behavior therapies that go along with medication-based therapies. We do know still that there's also a large private market for addiction therapy as well that's outside of the publicly funded system.
And what would the kind of medication look like? What's available right now?
I'm actually going to turn that over to
Thank you,
Dr. Patty to answer that one.
Thank you, Dr. Murdy, and to the chair, to you, Councillor Bravo. So presently at our treatment site, it's predominantly methadone and Suboxone, with a few adjunctive therapies, as Dr. Murdy had mentioned.
That's great.
Yeah.
Thank you. That's perfect. Thank you. In terms of the concern of the deputants about the connection between autism and vaccination, if you could just quickly say if there's any kind of medical evidence of that. But a second part of that is, The increase in cases of autism, does it have anything to do with the ability now and the availability of testing or diagnosis, I should say? And there was a sort of an autism is not normal, but there could be people in this room that have autism, and so I just wanted to just touch on that quickly.
Yeah, so to the chair, I mean, certainly the link between autism and vaccines has been disproven. There's lots of evidence to show that there has not been any causal effect between vaccines and autism. Autism itself is a very complex medical condition that really encapsulates a range of neurodegenerative conditions, and certainly there has been more of a diagnosis bias in that more people are aware of that condition, getting diagnosed and diagnosed with that condition. But it is an area of we still have a lot to know more, and certainly the range of that, the way that people are best treated by that, all of the other potential reasons that it's not just a diagnosis increase, that there may be other reasons, but I don't think we know all of those reasons yet.
And are we moving more toward kind of neurological diversity rather than divergence, or away from the idea that there's a perfect normal person that doesn't fit on any? There's no variety of brains out here.
I think certainly from an anti-stigma component, the more acceptance of neurodivergence is something that has been part of things we've seen with our school partners, with community partners, to be able to accept, and have that range of neurodivergence, and then people, it's not a yes/no condition.
So I have two more, which I'll do quickly. Mental health crisis in youth. We do have a particular strategy around that and looking at that, correct?
So certainly the youth component is captured within the Our Health, Our City mental health component as well. And as well, our partnership with Thrive Toronto is absolutely looking at youth mental health as a specific area.
And finally, is there major investments being made, including in the City of Toronto, the Universal Student Nutrition Program, increases in appropriate shelter, and also affordable housing? How long does that take to show up in public health and outcomes?
Well, I think there's some that could be very immediate. So certainly for that individual who gets housed, we know that is going to provide some stability into that person's life, and hopefully we can see a better trajectory and decreased visits to emergency departments and that immediacy. But as a broader population initiative, we know that this takes longer to really see that bigger initiative to say, how is it that harm reduction, how is it that housing is having that larger impact across a population, and seeing those improved indicators over time.
Thank you. Any other questions from any other directors? If not, I have one or two myself. Okay. So in your report, you referenced, maybe I mentioned it, the Heart Hub and the beds, the crisis beds. Can you speak to that a little bit as to how that's coming along, and if we've actually been able to fill those beds? I think it's 27 in total, right?
Yes, it's 25 beds that we have through the Heart Hub funding, and we have a number of clients. The numbers are changing on a day-to-day basis, so I hesitate to really even say, because I think today's numbers might be different than what we had on Friday in terms of the number of clients being assessed, but certainly through outreach services like our own Heart Hub services for addictions therapy, as well as core services, as well as our partner services through Toronto Community Crisis, as others have been referring clients to be assessed. And I believe 9 was the most recent. Was that Dominic?
That's the most recent number I have available. So that includes 5 TPH referred clients who are either signed a lease or pending.
And can you maybe talk about the services that are provided there? It's just not beds being provided.
So this is more permanent housing. So people who become tenanted into the site move into towards a rent geared to income model with extreme supports for wherever they are in terms of their mental health and substance use, to make sure that they are fully supported in transitioning into the home, continuing to have the kinds of supports that they need to stabilize through that. We know it is a recovery-focused model, but people don't need to be in recovery to be tenanted there. We know that there can be, cycles of relapse through the recovery process, and so clients who would be housed there are supported through that recovery process.
Wonderful. And just one final question on Our Health, Our City, the implementation table, which I chair. Can you maybe talk about some of the things we've been discussing there and some of the successes we've had around that?
So certainly the Our Health, Our City, and we didn't provide as fulsome an update on that, just to focus on some of the other areas, but we have our 3 main working groups in that table. One of them is focused on the supervised consumption site closures. That group is obviously very active currently with the announcement of further closures of 2 consumption and treatment services in Toronto. There's also an alcohol working group focused on the harms of alcohol. And again, we've had a number of recommendations moving forward in terms of how people are aware of treatment pathways for people with alcohol addiction. And we're also coming to that table with the follow-up and hopefully moving forward on the alcohol labeling strategy and bill that's being moved hopefully from Senate to House of Commons to move that forward federally. And then the third table that is a bit newer in development is the mental health and primary care access working group, where we're developing, I think, really some of the core kind of key areas that people are looking at. And we're also looking at making sure that group is very connected with Thrive Toronto, which is the partnership with a number of Toronto-based mental health agencies, and advancing the work through that forum.
Wonderful. Thank you. Any other questions from directors? Seeing none. We'll go to speakers. Any speakers on the item? No? Okay, I'll start. Councillor Chang, sorry. Do you have a question, Councillor Chang, or do you want to speak to the item?
No, I just wanted to speak to the item.
Go ahead, Councillor Chang.
Yeah, I want to thank staff for this tremendous report, as well as our medical health officer, Dr. Murdy. As you can see, our city has tremendous responsibility in a very complex context. And, when we hear the many deputations made, we can see that it's hard for one report to capture the breadth of the many health issues that our city has to address. So I think this is a good snapshot, but in no way can we be so comprehensive to drill down to every corner or facet, and each of them are important to the health of our city. So I do agree that I hope future reports do capture more about the treatment side and the outcomes of our many investments that are being made. But I do commend the work, and I think all of our cities should be grateful that we have such a comprehensive public health team that covers so many aspects of our health and our daily life in our city. So I just wanted to commend the team and thank them for this report.
Thank you, Councillor Chang. Councillor Ravo.
I want to add my thanks to staff, to Medical Officer of Health for bringing this report forward, and just to highlight how many of the concerns have to do with intersecting systems here. We have, if you think about all of the elements that are not clicking into place in Ontario municipalities, that would include having the downloading of social services and social housing to municipalities, in contrast to, for example, every other province, where you can look at what Manitoba is doing, what British Columbia is doing, where you have child protective services and the whole system with the provincial government. You have correction services with the provincial government, housing, and healthcare, importantly, because on the public health side, we deal with the outcome of broken systems, and certainly an important voice for ensuring that there are population-level interventions. But there are a lot of missing elements here, and I just want to emphasize above all of them housing. The experience of being homeless, we have learned over time, and certainly from medical professionals, is that it makes you more ill, and that being more ill and having to face very threatening situations, but even just being cold or being uncomfortable leads people to start to use more drugs. So the number one solution here is to give people a roof that's appropriate for them as soon as possible, in which a shelter is an important piece of that. It's a first step into a home, and then with the goal of a permanent home longer term. And this has such a, it starts with children. I think about how much work is being done in the City of Toronto to ensure that no family, no child is homeless right now, and we're doing great work. But unfortunately, things like a universal student nutrition program, which is very, every other country, OECD country anyway, and many countries all over the world with very inferior GDPs have had these measures in place. And there have been examples in other countries where, you have a period of time where every child received a school-based meal, and you look 20 years down the road, 30 years down the road, improved health there. So I think that with what we have and facing the complexity of what we're facing today, it's tremendous, and it's really wonderful to see the refocus and recommitment on social determinants of health. Thinking about the mental health crisis and where we are right now, it is significant. And once the children who are reporting at 65% thereabouts that they're more fragile mental health in all of Ontario, not just in Toronto, when they come of age, we're going to be facing more and more of the outcomes of that. But clearly care, investments in caring for people and ensuring that systems aren't broken is really crucial here. And I think that the big elephant in the room is that there is no mental health care available to people right now who need it most, not at the scale that's needed, and not at the in terms of publicly funded, publicly available. If you have a lot of resources, you can get care. If you have, if I need help, I have benefits. But the majority of people in this city work without benefits. They cannot see a psychologist, or they cannot get help when their health starts to waver or there are challenges. And that includes parents with kids who are the most neglected. There has been a lack of mental health care for children in this province for as long as I've been following this, since my daughter's now 30. So I've always been concerned about this, and I see the decline in what it does. Inequality, income inequality, the high cost of housing, the low wages, the high cost of everyday things is a real pressing thing that people are experiencing, and I think we see the outcome of that and the expression of that on our streets, in our communities, in our own families every day. So it's really precious what we do here at Public Health, and I want to thank all of the staff who've contributed to this, and I look forward to the work to come. Thank you.
Thank you. Anyone else speak? Okay, then I'll speak then. Again, I too want to thank not only the administrators of public health, but really the frontline workers who do such great work each and every day, serving every corner of our city. In regards, we don't even notice it, but, dine safe and swim safe, even now FIFA, public health is involved in all those things. Not to mention the immunization of our children. We've had Mpox outbreaks, measles outbreaks this year. Public health has been front and center in addressing all these issues. I don't know. Our city population now, I think, is at 3.2 million people, and public health has been doing with the same similar budgets, serving so much more of our population. Not to mention everyone who come and visit our city every year for different festivals and events and so forth. Even Taylor Swift, for example, right? Millions of people came here, and public health was front and center. But we also know that the province is supposed to cover 75% of our public health budget, and the city covers 25%. And in this year's budget, it was really 69-31, right? So we actually, again, time and time over again, covering the cost that the province fails to do so. And so that needs to be front and center. But I just know that the work we do here is amazing, and I'm so thankful to be part of it. I see, as chair of the Board of Health, I see it every day, going into different communities and speaking to staff and so on and so forth, and showing the appreciation to us here at Public Health. So yeah, I just wanted to say that out loud and keep up the good work. And thank you for this snapshot. This snapshot really doesn't really show the breadth of what we do here, but you know, it would take the entire meeting for her to do that. So thank you, Dr. Murdy and team. Alrighty, I will ask Director Zhao to move this item. All those in favor? Opposed? Carried. The next item is item number 2, which is actions to advance Indigenous health. There's a presentation on this item. I'll have Dr. Murdy speak to, introducing those who are going to speak to it.
Thank you, Chair Moyes. We'll be turning it over to Monique Diabo, who will be speaking and presenting the item.
Good morning, Chair, members of the board. Thank you for the opportunity to speak with you today. My name is Monique Diabo. I'm Ganyagehaga, Mohawk, and Taino, originally from Ganawage, Mohawk Territory, raised in Kehewin, Alberta, Treaty 6 Territory. And this is my colleague and team member, Josh Swain. He's Red River Métis, originally from Kinnesota, Manitoba. This presentation provides a comprehensive update on Toronto Public Health's actions to advance Indigenous health. While you've received several focused updates over the past year, including those on cultural safety, the Indigenous Wellness Committee, and the Indigenous funding stream of the Toronto Urban Health Fund, today's presentation brings our full portfolio together over the last 2 years. Well, you'll see how the work has deepened, how Indigenous leadership continues to shape direction, and how we're preparing for the next phase of implementation in 2026 and beyond. The purpose of this report is twofold. First, we're providing a broad update on all actions taken since the board's January 2024 report on Indigenous health. That includes progress on cultural safety, mental health and substance use, Indigenous-led vaccine partnerships, funding approaches, and Indigenous data governance. Second, we're reaffirming Toronto Public Health's community to culturally safe, Indigenous-led approaches. This commitment is essential to ensuring public health is responsive to the needs of the urban Indigenous community in Toronto. This work is grounded in reconciliation and reducing inequities caused by long-standing systemic harms, and in honoring the priorities Indigenous partners have consistently raised with us. Toronto Public Health's Indigenous health work is guided by multiple intersecting mandates. The Ontario Public Health Standards, the City's Reconciliation Action Plan, Toronto Public Health's strategic plan and direction from this board. This work is also guided by Indigenous leaders, community members, and knowledge keepers. This slide summarizes the core areas where we've advanced Indigenous public health action since January of 2024. Each area aligns directly with priorities that Indigenous partners have repeatedly communicated to us. They include mental wellness, reducing harms related to substance use, cultural safety, supportive housing, and social determinants of health, Indigenous-led vaccine approaches, Indigenous funding, data sovereignty, and emergency response. Taken together, these demonstrate the diversity and reach of the portfolio and the shift towards Indigenous-defined and Indigenous-led public health pathways. These focus areas work to address critical public health priority areas as communicated by Indigenous partners. Mental health and wellness supports, reducing the harms related to substance use, Indigenous cultural safety across health services, supportive housing, and addressing social determinants of health relevant to Indigenous communities, and Indigenous, self-determined, and non-competitive funding. This slide reflects one of the most important shifts in our work. Previously, our approaches were often evolving and time-bound, with growing recognition of the importance of sustained engagement and strengthening Indigenous governance structures. Over the past several years, particularly beginning during the pandemic, we've moved decisively toward co-development, Indigenous-defined priorities, and shared decision-making. Indigenous organizations are no longer contributors. They are co-leaders. This shift is grounded in trust. It really is rooted in relationship, and it reflects a long-term commitment to working with Indigenous communities rather than consulting them. Our team spends a significant amount of time attending and contributing to engagements led by Indigenous service partners, usually at the invitation of host organizations. Above, you will see some examples of such events we've been part of. The grand opening of Anishinaabe Health's new purpose-built Indigenous Health Center, as well as a DOJE, Indigenous Primary Health Care and Wellness Clinic's TDSB Indigenous Immunization Clinic, and Council Fire's Wellness Gathering, among many others. We always find a way to balance our commitments, to provide internal expertise and contributions across Toronto Public Health's directorates, and time spent in community fostering and nurturing relationships, and participating in informal dialogue about current Indigenous health issues with the organizations on the front line and how we can support. When asked why we feel this is important to dedicate our team's resources to such commitments, we state the following: visibility, reciprocity, and leadership drive trust and partnership. Consistent presence at community-led gatherings builds rapport and legitimacy, demonstrating that Toronto Public Health values Indigenous voices and is committed to meaningful engagement. This visibility, particularly in spaces where trust has been historically fragile, signals respect and strengthens Toronto Public Health's role as a genuine partner. Participation also reflects reciprocity. By showing up for community, we foster mutual engagement and shared responsibility, making collaboration more effective and grounded in relationship. The Indigenous health team plays a key role in fostering these connections, bridging gaps between Toronto Public Health and Indigenous service providers, and transforming relationships into strong, ongoing partnerships. Senior leadership presence further reinforces this commitment, signaling that Indigenous health is a priority at all levels of the organization and strengthening trust through visible top-down support. Indigenous leaders are heavily relied upon and contribute a significant amount of their time to various tables, leadership circles at a municipal, provincial, and federal government level. We at Toronto Public Health recognize that because leaders are pulled in so many different directions, engagement fatigue can limit their availability to participate. By showing up for these organizations, we demonstrate that we value those contributions, especially to our own initiatives like the Indigenous Wellness Committee. This commitment to community and partnerships is exactly what is required to create lasting collaboration and has been a key factor in enabling the strong, sustained co-development we've seen within the Indigenous Wellness Committee. This work began in a good way by following traditional protocol and offering each of the participating organizational representatives tobacco. This reflects our team's understanding of Indigenous ways of knowing, being, seeing, and doing, and signals that we are entering this work with respect, with intention, and accountability. This is not a symbolic or performative act. It represents a commitment to relationship. In many ways, it's seen as a contract in spirit, guided in reciprocity and trust. We've heard directly from Indigenous partners and leaders that this decolonial approach has been meaningful and appreciated. By centering protocol alongside our public health responsibilities, we are demonstrating that this work is not extractive or transactional. Instead, it is rooted in ongoing relationship, respect, and ongoing presence. This has helped build trust and confidence with Indigenous service providers, reinforcing that we will show up, not just for the moment, but over the long term. Ultimately, this approach has laid the foundation for enduring partnerships that will carry well beyond the development of the Indigenous Wellness Action Plan and support sustained community-led work into the future. The Indigenous Wellness Committee is central Indigenous-led governance structure co-guiding this work. It was established in April of 2024, following this board's direction. And since then, we've convened 13 informal meetings alongside ongoing planning, relationship building, and working sessions. 17 Indigenous-led organizations sit at the table, and all 26 Indigenous organizations in Toronto are kept engaged and informed through summaries and validation opportunities. The committee uses Indigenous frameworks and research methodologies guided by Indigenous knowledge keepers. What we want to emphasize here is impact and engagement. Committee members are giving their time, their expertise, and their knowledge on behalf of their organizations to ensure that the plan we ultimately bring forward reflects Indigenous worldviews, Indigenous wellness, and Indigenous priorities. This structure helps address consultation fatigue by creating a stable, trusted, Indigenous-led space for ongoing governance. We are now entering the drafting phase of the Indigenous Wellness Action Plan. This work is not only happening externally, we are also transforming Toronto Public Health internally as well. Through the Indigenous Cultural Safety Action Plan, Toronto Public Health is shifting from mandatory education into more experiential learning and more relationship building and more integration across programs. Programs are adapting their practices based on Indigenous-defined wellness. Relationship-based engagement is becoming common practice across the division. Staff are attending learning events, screening films, guest speaker sessions, and evaluation data shows these sessions have a strong impact and relevance. This internal capacity building is essential. As Indigenous partners contribute to more of the governance and direction setting, Toronto Public Health must continue to grow its cultural safety practices to be able to work in good relation. Since 2022, Toronto Public Health has been working closely with Indigenous service providers to establish a collaborative approach to advancing Indigenous harm reduction. In partnership with Ontario Aboriginal HIV/AIDS Strategy and Indigenous Harm Reduction Circle was officially formed in February of 2023. The Circle's mandate includes co-developing culturally appropriate solutions for Indigenous harm reduction and identifying strategies to address the health and wellness needs of Indigenous people who use substances. The Beaded Naloxone project is a community-led response to the Ontario government's Community Care and Recovery Act, which mandated closures of 5 supervised consumption treatment sites in Toronto by March 31st, 2025, including Indigenous serving programs and Toronto Public Health's The Works. These closures will disproportionately impact Indigenous community members who are already navigating inequities rooted in colonial violence and systemic racism and intergenerational trauma. Inspired by the Yukon Council of First Nations, the Indigenous Harm Reduction Circle has engaged an Indigenous beadwork artist to create a beaded naloxone kit, serving as the anchor for a culturally relevant awareness campaign that promotes Indigenous-led harm reduction services and strategies across Toronto. Participating organizations include the Native Canadian Centre of Toronto, Four Winds at Parkdale Queen West, Toronto Aboriginal Support Services, Ontario Aboriginal HIV/AIDS Strategy, Two-Spirited People of the First Nations, and the Women of the Métis Nation. This slide highlights what Indigenous partners tell us they are experiencing as a result of these shifts. We constantly hear we should not be forced to compete for limited funding when we're all working towards the same goal. Reporting needs to be Indigenous governed and non-colonial. Vaccination services should be Indigenous-led wherever possible, with public health supporting capacity building. These quotes represent a broader theme. Indigenous communities are seeing meaningful changes. Examples include low barrier, self-determined allocation of the Indigenous Toronto Urban Health Fund funding, the Indigenous Harm Reduction Circle, and the Beaded Naloxone Initiative. Culturally grounded emergency response supports for evacuees, including increased access to oral health and immunization, and stronger collaboration in youth health, mental health, substance use, and vaccination pathways. These are concrete public health impacts. Looking ahead, our work focuses on strengthening Indigenous public health capacity through Indigenous-led partnership. This includes completing and validating the Indigenous Wellness Action Plan, strengthening Indigenous-led mental health and harm reduction pathways, deepening cultural safety transformation within Toronto Public Health, and continuing to develop sustainable Indigenous-led funding models. We are moving from doing work on Indigenous communities to working with and alongside communities, where Indigenous partners co-lead and Toronto Public Health supports through resources, accountability, and public health infrastructure. For the board, continued leadership will be essential. By supporting Indigenous governance principles, advancing cultural safety learning, endorsing Indigenous-led funding pathways, and ensuring timelines reflect community capacity, we bring forward recommendations in our report for action, which we feel will enable Toronto Public Health to continue strengthening our approach to public health that meets the needs of the Indigenous community. Together, these actions will continue moving us forward towards a public health system that upholds Indigenous wellness, self-determination, and reconciliation. Hi, Nyawe. Thank you.
Thank you so very much. We do have one speaker on this item, Brooke Coatsworth. Online.
Excuse me.
Brooke Coatsworth, are you there? You can see your name on the screen. If you want to speak to this item, can you unmute yourself? Yep. Going once, going twice. Mr. Coatsworth? Okay, we'll move on. Any questions from directors? Go ahead, Director Madar.
I want to start by saying thank you so much for the report today. I got to read it on the weekend, and as a community member, I also want to just acknowledge how I felt the shift actually that Toronto Public Health has been making in the community as a member. So I would just want to acknowledge that and say thank you so much. And in particular, one of the things that I was really encouraged to see in the report was all of the work around Indigenous cultural safety that the organization has been doing, because of course, partnerships and the systems, the sort of work that y'all are doing must be supported by internal work, right? That's happening within the organization. I have a couple of questions. My first question, which you spoke to quite a bit, was around the work that the organization is doing around cultural safety. I was wondering if Toronto Public Health is measuring that work. So both in terms of like the implementation of the plan around training and policy development and partnership approaches, but also around the outcomes of the work for our communities. And in particular, if that work is underway, how our communities are being involved in defining what success looks like for TPH.
Thank you very much for that question, Ms. Matter. I appreciate that. Yeah, so around cultural safety, Toronto Public Health evaluation feedback shows that internally, there has been an increased understanding of Indigenous histories, Indigenous realities, and how they impact and or influence the work. There has been greater confidence in applying cultural safety principles and very strong relevance to governance and service delivery roles. Toronto Public Health has also made training mandatory at this point, with ongoing monitoring and support for its completion.
She just asked how we do through the Indigenous Wellness Committee.
Yeah, and in terms of how we get, how we include community through the Indigenous Wellness Committee, like we shared earlier, many of the representatives from the 17 Indigenous service providers share with us what is needed and how to go about implementing cultural safety in the community. So one of the examples that we shared was through our vaccination programs. So for example, something that we have been directed to do is to allow our Indigenous service providers, so for an example, Anishinaabe Health Toronto or Doje, to first address the vaccination process, and when they don't have the capacity, for us to go and to support them. And that was directly related, especially to cultural safety, recognizing that when they are having, for example, vaccine clinics for the Toronto District School Board, some of the administration and the students would rather see themselves represented in those teams or crews that come in.
Thank you so much. My second question was around data governance, and I noticed it was one of the areas in the report. You didn't speak very much to it in this presentation, but I was curious what that work will entail over in 2026 and what we can expect from that.
I'm actually going to pass that question over to, through the chair, to our medical officer of health, or Emma, our manager, Emma.
I know we're running out of time, so I'll just jump into that to say, I think we're still in development stage for the data governance. We're certainly working closely with Dr. Janet Smiley, who's a leader in Toronto in this area in terms of looking at how we can have an appropriate data governance structure to be able to not just collect, but use and share and have that ownership of any Indigenous data we are collecting. We have moved forward on a sociodemographic data pilot project where we've started collecting this information through our Healthy Babies, Healthy Children program to be able to kind of look at, and some of our other early years programs to see which clients we are serving and working with them to understand that the ownership and the appropriateness of how we would be sharing that data going forward. But certainly lots more to come, I think, as in a future update on how we're proceeding.
Yeah, Ms. Matter, if I could also add to that, as Dr. Murty shared, we're working with Dr. Janet Smiley. We're also working with some other Indigenous service providers on this, including Call Auntie and Native Men's Residents of Toronto, known as NAMI Res.
Thank you. Go ahead, Councillor Bravo.
Thank you very much for the presentation. It was really great to read it ahead of the meeting. On the experiential learning part, I really I'm interested in whether you would be looking at how we learn as a board. The shift from training to experiential learning is, I think, a pretty significant part that you commented. It's really helping public health staff, and I'm just wondering if that's potentially a recommendation in the future.
I know that something that has come forward is that the board has mentioned that they would like to continue the cultural safety training. So we're hoping to move forward with that in 2026 or 2027. And when you're talking about experiential learning, that's actually a really great question, Councillor Bravo. I think on behalf of myself and our Indigenous health team, we can say for councillors or member of the board to get out into community. There are multiple gatherings. You know, I spoke to some of the health gatherings. I spoke to some of the more social gatherings. Get out into the community, go to those gatherings, you know, experience the gatherings, and also, you know, meet and get to know your Indigenous constituents, because you have many in your areas. And that in itself, I feel, is experiential learning, among others.
Absolutely right. Thank you.
Thank you. Any other questions from anybody? I just have one. It was touched on already, but are there any gaps that you see perhaps that needs to be filled? I mean, again, I know that this is a comprehensive report and a lot's been done, and I'm happy for the feedback that's been received based on the data that was collected from the members. But are there gaps that, you know, they would like us to perhaps address?
Yeah, I think I'm going to actually pass that question to Dr. Murty.
Oh, thank you, Chair. You know, I think we have made a lot of progress into the space, and I think certainly the recommendations that are moving forward in terms of not just continuing, but actually strengthening the work that we're doing. So looking at increasing that amount of funding that we were able to provide through the Toronto Indigenous Health Fund to further that the work that we're able to do in that space. I think really looking at solidifying, making not just Indigenous cultural training for our staff as optional, but actually moving towards a more mandatory requirement to really make sure that we're having that deep penetration across staff, and that there is, you know, that level setting across all of our staff. And then continuing, you know, we know we'll have evolution of the board through the end of 2026 and early 2027. And so really our commitment to making sure that we are moving in lockstep with the board in terms of that, that training, and providing yourselves, you know, what we need in terms of that strategic oversight to move this work forward.
Okay. Wonderful, thank you. Seeing no other questions on this item, moving to speakers. Any speakers on the item? No? Well, thank you for this very comprehensive report. Again, it's nice to learn from you and with you as always, and we look forward to hearing any further updates as time goes on. So thank you so much.
Much appreciated.
And I like your feedback on going into community and seeing for yourself. I've had the privilege of doing that many times. Most recently at the Anishinaabe Health Center down in my ward, down on Cherry Street, I think it is. It's a great facility, and I encourage anyone who hasn't been there yet to please come and visit. Thank you. Okay, who'd like to move this item? Okay, Director Medor. All those in favor? Opposed? Carried. Thank you. Okay, next item is item 3, health impacts of homelessness and update on the downtown core pilot. We have a presentation on that. Director Dr. Murdy, you want to introduce the panel members?
I'll be presenting this item, Chair.
Oh, will you? Okay.
But they're thankful to guests that we have in the audience from our Toronto Police Services. You are absolutely a key partner in this initiative. So today I'll be providing a brief overview of the health impacts of homelessness and the actions Toronto Public Health is taking, including an update on the Downtown Community Outreach Response and Engagement, or CORE, pilot program. We are bringing forward today to support Toronto Public Health's commitment to advancing the health and well-being of people experiencing homelessness, an issue that continues to affect many Toronto residents. To provide a brief overview, at the end of January of 2026, there were over 11,000 people experiencing homelessness in Toronto. Indigenous, racialized, Black, 2S LGBTQI+ communities are overrepresented among those experiencing homelessness. Based on birth records assessed before the pandemic and since, and in collaboration with Toronto-based network Young Parents of No Fixed Address, we have consistently seen that approximately 300 births per year are to people experiencing homelessness. An extensive body of evidence shows that the physical and mental health outcomes of people experiencing homelessness are worse than the general population. Compared to housed groups, people experiencing homelessness are at increased risk of premature death and have a higher incidence of chronic and acute health conditions, including infectious diseases, diabetes, cardiovascular disease, and respiratory disease. Acute drug toxicity is identified as the leading cause of death among people experiencing homelessness, contributing to 55% of the reported deaths in 2024. In Toronto, the median age at death of people experiencing homelessness in 2024 was 50 years old for males and 38 years old for females. By comparison, the median age for death at the Toronto general population was 78 for males and 85 for females, almost a 50-year gap for females. Homelessness can result in health harms across the lifespan and negatively impact an individual's health trajectory over their lifetime. The health impacts of homelessness are clear. Downstream healthcare costs of homelessness are also substantial. Annual healthcare expenditures can be roughly 7 times higher for people experiencing homelessness compared to housed individuals. Toronto Public Health plays an important role in surveillance and leads the collection and sharing of health-related data for people experiencing homelessness. Given the extensive health and social impacts of homelessness, these data are important for understanding the healthcare needs of this population. In addition to surveillance, Toronto Public Health undertakes a range of actions to protect and promote the health of people experiencing homelessness, including direct program delivery and collaboration with city partners. The staff report includes Toronto Public Health initiatives as examples of this work, and I'll highlight just a few of those today. Our Homeless at Risk Prenatal, or HARP program, is a community-based program delivered by public health nurses that supports individuals who are pregnant and experiencing homelessness, including those living in encampments, respite centers, and adult-only shelters. Our Communicable Disease Investigation and Outbreak Liaison Program leads public health management of outbreak investigations within the shelter system and supports respiratory season preparedness. Toronto Public Health's mobile dental services provide preventive, minimally invasive, and restorative dentistry directly in community settings, such as community health centers and shelters, supporting oral health needs that often go untreated due to homelessness or unstable living conditions. And our newer initiative, the Downtown Core program, is the focus of the next few slides. In December of 2024, Toronto Public Health and Toronto Police Services launched the Downtown Core pilot program. For this collaborative program, public health nurses are paired with police constables to deliver integrated, low-barrier, mobile outreach and case management in the Yonge and Dundas or Sankofa Square and the surrounding area. Downtown Core aims to connect people experiencing homelessness, mental health, and substance use challenges with health, social, and wraparound services. This highlights some service metrics of the Downtown Core program up to January of 2026. Public health nurses during their nursing shifts documented 8,431 client interactions across 568 shifts, working alongside police constables. 90% of these interactions were initiated by the Downtown Core team, reflecting the proactive outreach approach. Police constables work with nurses to support a safe environment for clients, staff, and the broader public. They can also assist with system navigation for services within their purview, such as legal aid. During program shifts, clients most frequently received psychosocial supports, which was provided during 97% of shifts, as well as medical support, which was provided during 63% of shifts. There were 265 clients served through case management, which most often involved helping clients access emergency or transitional shelters, primary care, identification services, income supports, and accompanying clients to appointments. The Downtown Core team has supported securing housing for 9 clients through case management services. Public health nurses addressed clients' immediate medical needs through overdose response, emergency care, and supply distribution, including naloxone and food. Toronto Public Health conducted an evaluation in February of 2026 to inform the pilot's next steps. This included a survey with clients, focus groups with Toronto Public Health nurses, and program management, as well as review of the program data. The evaluation demonstrated that public health nurses are providing proactive outreach and on-the-spot support to connect clients experiencing homelessness and complex health needs to health, social, and wraparound services. The most beneficial impacts of the program were addressing clients' substance use and addiction needs and connecting them to housing and identification services. The evaluation identified opportunities to enhance the program, including expanding the scope of the public health nurses, strengthening referral pathways, as well as the Toronto Public Health and Toronto Police Service collaboration. There are several key recommendations included for the Downtown Core pilot. The Downtown Core pilot program should be extended for an additional 18 months to build on what we've learned to date while allowing additional time to continue to assess the pilot. Staff will report back to the Board of Health with final recommendations on the pilot in the third quarter of 2027. We will continue to work closely with health system partners and relevant City of Toronto divisions and agencies to improve the health and well-being of people experiencing homelessness. This collaboration is essential to addressing complex health and social needs and strengthening interdivisional outreach and case coordination. As a next step, Toronto Public Health will review the evaluation findings from the separate program evaluation commissioned by the Downtown Yonge Business Improvement Area once they are available. The Downtown Yonge BIA sits on the Downtown Core Advisory Committee, which oversees the program and is co-chaired by senior leadership from Toronto Public Health and Toronto Police Service. TPH has actively participated in the Downtown Yonge Business Improvement Area evaluation process by sharing program data and through staff involvement in the evaluation activities, including interviews and focus groups. Toronto Police Service is also engaged in this evaluation. Pending extension of the Downtown Core pilot program, Toronto Public Health would move forward with implementing enhancements identified through the evaluation. This includes strengthening collaborative service delivery by Toronto Public Health and Toronto Police Service, as well as improving referral pathways to primary care. We will examine the impact of recently implemented services that aim to provide more on-the-spot clinical care. This includes expanded public health nursing functions, such as basic wound care introduced in February of 2026, and immunization services that began just last week. Finally, we would adjust the catchment area to improve better service coverage to better meet clients where they live, gather, and access supports, and to strengthen coordination with key community organizations and city divisions. As shown on the map, the primary service area would be slightly increased to the north and the south, represented by the lighter blue area on the map, and the red outlined would not be part of the primary service area. However, this zone represents locations where outreach and engagement would occur on an ad hoc or as needed basis. In closing, I would like to thank Toronto Public Health and City staff, our colleagues at Toronto Police Service, and other partners for their ongoing collaboration and commitment to improving the health of people experiencing homelessness.
Thank you, Dr. Murdy. I see we have some speakers on this item. First up is Pauline Larson. Are you here, Pauline? She online? No? Here she is, yeah. Pauline?
Can you hear me?
You can, go ahead. You have 5 minutes.
Excellent. Okay. Thank you so much. Chair Moyes and Dr. Murty and members of the Board of Health, thank you so much for having me here today. Just trying to get my camera started, so you should see me in a moment. All right. Does that work?
We haven't seen you yet.
All right. Shall I just get going rather than hold things up?
Go ahead.
All right. So let me start by saying that I'm here to depute today in support of Dr. Murty's recommendation to extend the community outreach response and engagement pilot in the Yonge Dundas area until Q3 of next year. I thought I'd start with a little bit of an overview about who Downtown Yonge Business Improvement Area is, especially for those of the new board members who haven't come across us before. We are the business improvement area around the Yonge and Dundas neighborhood, and we represent approximately 2,000 businesses as well as commercial property owners with a combined commercial property value of just over $7 billion. We're one of the largest BIAs in the city, and we generate approximately $850 million a year towards the different levels of government revenues, municipal, provincial, and federal. We have always taken a very intentional and collaborative approach to community safety and well-being. That started a decade ago, in fact, in 2015. And for instance, we have funded a full-time outreach program that serves the community in our neighborhoods since 2018. And since 2021, we have coordinated a weekly partnered outreach program with up to 8 or 9 different on-street partners, including partners from the works when the supervised injection site was still open, as well as our neighborhood community officers, as well as MDOT and Streets to Homes, among several others. So our goal is to provide wraparound services to clients on street and to support community safety and well-being in the broader neighborhood. So we would like to acknowledge that in a neighborhood where community safety and well-being has been raised as a concern in recent years, the core pilot has made a really significant impact, not only for access to services for their clients on street, but also to the greater sense of care and safety in the neighborhood at large. And for us, of course, this is something that is very critical. The medical officer of health outlines clearly and extensively the benefits of the core pilot on people experiencing vulnerability and homelessness in her report. But in addition, we would like to underscore the heightened sense of care and safety that CORE brings to the broader downtown Yonge neighborhood. Since 2018, we have undertaken an annual safe and inclusive neighborhood survey to assess levels of perceived and actual community safety and well-being in our neighborhood. We include employees, residents, students, visitors, and business owners in this survey. And in 2025, the survey, which was undertaken in September, just 8 months into the CORE pilot program, asked about awareness and interaction with the CORE team. we found that 21% of all survey respondents, and again, that's across business owners, commercial property owners, employees, residents, students, and visitors in the neighborhood, were aware of the core team, and a further 5% had interacted with them directly. I really want to highlight how positive an impact that is in a program which was only 8 or 9 months in at the time, and which has, created a very high level of awareness over that very short period. More broadly, we at Downtown Yonge are dedicated to working collaboratively with the City of Toronto, among others, on safety initiatives that focus on the intersection of both safety and well-being. We see those as two sides of the same coin. As Dr. Murty mentioned, we do sit on the Core Advisory Committee. We also co-chair the city's Downtown East Leadership Table and have done so since 2025. We are an outreach provider that participates in the Downtown East Focus Table. And we also are active participants of the Young Dundas Safety Network, which meets every 3 weeks. Finally, we also partner and have done since 2023 with the city's SafeTO Community Safety Plan on the SafeTO BIA program, which is funded through the city but based at Downtown Yonge. So those are my remarks. I just wanted to say again, thank you for the opportunity to submit this deputation in support of the recommendation. And I hope to look forward to continue to work with the team at CORE and at the Toronto Public Health as we go forward. Thank you very much.
Yeah, thank you. Any questions for the deputant? I do have one. So Pauline, you mentioned that 21% of people surveyed are aware of the program and 5% has interacted. Have the business community and perhaps residents in the area, have they seen an improvement in public safety or perhaps, perhaps less disorderly behavior in the area, in your catchment?
So my response would be specifically with regard to the perceptions of safety, because I think that what is often not fully understood is that people don't come to areas where they don't feel safe. And safety and crime can be very, very different things. There is a greater sense among our membership and also the larger stakeholders that we work with in the community that there is care being shown to individuals that are on the street, that there is a compassionate response. It is a multidisciplinary and collaborative response, which from our perspective is highly effective. And for us, that has made everybody feel like, okay, we're doing something. We're actually trying to help. We're trying to provide solutions. And from our perspective, that is probably has the most positive impact on community safety as anything else. I think in terms of the actual change, as Dr. Murty's data showed, 8,500 engagements is a pretty impressive number over just on a year period. And I think they speak for themselves in terms of how many people are being helped and provided with resources. So yes, overall, I would say this has created a very positive impact on the broader community.
Well, wonderful. Thank you. Those are my questions. Sorry. Director Zhao has a question for you, Pauline.
Absolutely.
Hi, Pauline. Thanks for the wonderful letter that you put together with all of the data. And I'm really curious what the data looks like now, because the data you mentioned was from 8 months into the core program. And correct me if I'm wrong, but the core program started between 2018 to 2021. And so I'm just kind of curious, what kind of improvements have you been seeing in 2025, 2026?
So it's a great question. It is an annual survey. So the last one that was done before that in 2024, the core pilot had not been yet launched. So this is the only year where we've been able to ask the question about people being aware of or interacting with the core pilot. Did that answer the question?
Great. Thank you for answering the question. I guess just to follow up on that is, you're tracking the data year by year and determining the business owners, the visitors' impressions of increased safety. And so there is data being collected currently on decreased number of break-ins, for instance, thefts, overall sentiment of safety. Is that kind of the metric that you're looking at?
So no, this specifically is an annual survey that is conducted in September of every year, asking people around, do they feel safe? What makes them feel safe? What makes them feel unsafe? How have they seen various different interventions? We ask extensively about our own outreach program to see if that is being well received by the community. We ask about our neighborhood community officers. We ask about experiences of various different types of incidents, but it is a once a year survey that specifically asks about perceptions of safety and an understanding of how the neighborhood has improved or not over the course of that time. We've been doing those surveys, as I said, since 2018, but the core question was only asked for the first time in 2025.
Great, thank you for clarifying the answer.
Absolutely.
Thank you. Any other questions for Pauline? Seeing none already. Up next is Bita Senejani. Online. Bita, are you there?
Hi there. Yes, I am here.
Okay, you have 5 minutes. Go ahead.
Thank you. Thank you. Good afternoon, and thank you, Chair. My name is Bita Senejani, and I'm with the Canadian Drug Policy Coalition, a national nonpartisan policy organization working to support the implementation of drug policy grounded in public health and human rights. As the most populous municipality in the province, we prioritize making this appearance today, and we urge action from this board and your counterparts across the province. And I'm also here as a Toronto resident deeply concerned by decisions that will impact my community. I'll be addressing the recent defunding and possible imminent closure of additional supervised consumption sites, which will have disproportionate impacts on people experiencing homelessness in Toronto. While surely not everyone who is homeless consumes drugs, and while not everyone who consumes drugs is homeless, peer-reviewed research shows that in 2021, 1 in 6 people who died from opioid toxicity in Ontario was a person experiencing homelessness. The defunding and closure of supervised consumption services will significantly harm people who use drugs, people who experience extreme poverty and homelessness, gender minorities, women, and Indigenous people. These have implications for this board's reconciliation efforts, as well as other frameworks designed to reduce health disparities among these marginalized populations. Access to addiction treatment and access to harm reduction must go hand in hand. It is widely accepted that for anyone who chooses to do so, the pursuit of abstinence is not a linear process. The increase in overdose risk immediately following a course of addiction treatment is well documented in the research, and therefore harm reduction and supervised consumption must be made available alongside one another. The unregulated and toxic drug supply is leading to increasing rates of death and irreversible injuries such as hypoxic brain injury.
Just frozen. Hopefully she'll be back shortly. Did we lose her completely? Bita, can you hear me? Bita? Right. Looks like this is a city problem. We'll wait for a minute.
creating barriers for renters who may consume drugs by passing Bill 10, the Protect Ontario Through Safer Streets and Stronger Communities Act, which punishes landlords with significant fines and possible imprisonment for knowingly so-called permitting people who produce, share, or otherwise supply drugs in their rental unit. This will mean fewer landlords will rent to people who use drugs and may increase evictions. There will likely be hotspots of overdose emergencies in specific areas of the city should the site closures be permitted to proceed by this board. My recommendations to this board are as follows. 1, take all action necessary to ensure the remaining sites in Toronto which have been defunded can remain operational. 2, request that the medical officer of health work with other city divisions and urgently set up an emergency response table that includes paramedics, library workers, supervised consumption site workers and clients, drop-in and shelter workers, and other community organizations and medical professionals to participate. Request that the medical officer of health work with the Toronto Shelter Support Services on a strategy for providing medical directives on oxygen for shelters and drop-ins. That was 3. 4, request that the medical officer of health provide a follow-up on the anticipated impacts of the SCS closures report and include a summary of current impacts and recommendations. And 5, please make a statement supporting supervised consumption sites services as public discourse matters and evidence and expertise in disease prevention must guide our policy. Thank you.
Thank you so much for your deputation. Any questions for the deputant? Thank you so much for coming in today. Norad Buzaid? NORAD? Not here? Okay. Brooke Coatsworth? Not here. Okay. Sev Taylor? Councilor Pritza, can you turn your camera on? Sev Taylor? There we go. I see Sev down below here on my screen. Sev, can you go get off mute? Here you go.
Hello. Before my 5 minutes start, Beta is owed 1 minute. So I cede the floor for the moment. Thanks.
Sorry?
So Beta is expecting to speak for 1 minute.
Beta spoke already.
For 4 minutes, I believe. So I cede my time for the time being.
I'm not quite sure what you mean by that, but it's your time to speak. You have 5 minutes. Go ahead.
Okay. So watching say little Tansy. Hi everybody. Let me see if I can get the video on. Okay, hello. My name is Sev. I'm a harm reduction worker. It's difficult to talk about this. It's almost like there's two cities, right? And I feel like I have one foot in both. I don't have a fixed address at the moment, but my friends have been very kind. You know, I have, like, I've been to university. I've also been the person sitting on the floor outside having a panic attack, and a police officer walks by, and I fear that my distress is going to be taken as an indicator of threats. I've written about my experiences with the mental health system and an article, which, if I may, I'd like to point you to. It's at 999queenwest.medium.com. It's 999queenwest.medium.com. But my main point I would like to bring today for consideration concerning the extension of the core pilot project is that I completely vibe with the concerns that have been stated about the health impacts of sleeping rough. I think it's also very important for the Board of Health to bring its sustained attention to people's honest experiences of institutionalization, whether that's through direct coercion or whether they have to be in a shelter because there's no other survivable option that night. I'm not trying to impugn anybody's good efforts here. My point here is simply to bring up that I think that if we're taking a city level equity-focused, just health approach here, then out of sight, out of mind is not sufficient. What I'm saying is that just because somebody's off the street, they may still need to be checked up on, because for as much care as is provided in these respite institutions, hospitals, etc., there's also a lot of stuff that, say, Duncan Campbell Scott would be really proud of. So I'm tripping on my words. There's so many things I wanted to say, but this is so close to home for me. I guess I would just encourage also my fellow frontline workers, including the TPS folks who are here today and who are involved in the core project, to just really look after your health on a profound level. Maybe reflect on what Sankofa means to you. To me, I don't have time to get into my whole background. I'm a settler here, but I vibe with the proverb associated with the Sankofa Adinkra symbol, and that proverb is often translated as, "It is not taboo to go back and fetch what you have forgotten." So, yeah, the more that frontline workers can proactively center themselves and operate from the best instincts that brought them to whatever profession, rather than from any stigma or snap judgments, fear, aversion, pity, anything like that, that's going to be a major health factor for the population as a whole. And I would particularly encourage TPS folks in the room to consider picking up this book, share it with your colleagues, use some of the program budget for it. It's called My Grandmother's Hands, and it's a really powerful tool for what I like to think of as restoring the circle. This is a little tangential, but I was chatting about this with my partner and colleague, Tyler Kaur, who has a background in construction engineering and is a nurse. And we got to talking about the tiny shelters. And so he really wanted to advocate for that as a community-led measure for helping people transition away from sleeping rough, but in a way that's consensual. Again, reminding you all that self-determination is a very important factor for minimizing the harms of emergency response, and also like helping people to get connected with the housing situation and the lives and community that are aligned for them. And Tyler said, what matters is the people, that they get a fair shake and a decent life, a chance for a comeback story, dignity, respect. Thank you all very much for your time and for the work that you do.
Thank you very much, Sev. Any questions for the deputant? Seeing none. Thank you for coming in today and sharing your thoughts with us. Next up is Daniel Tate. Is Daniel Tate here? In the room, online? No? Okay, thank you. We'll take it in-house. Director Chandrabalan, I think you have a question. Go ahead.
Thank you, Dr. Murray, for the update. Happy to hear how things have been progressing and all of the work that's being done to evaluate. I think data is always the most important thing, especially when it comes to pilot projects, to see how we can better service the residents that we're hoping to service with this program. My question is, I know you're expanding area, you're expanding scope with the wound care, immunizations. What do you see as the, what is the pathway from these pilot projects? So we're expanding, but then is this something that we are hoping to make permanent? What are the variables in making this a program that's more permanent? And then I have a follow-up question to that.
Yeah, to the chair, thanks for that question. We have only really just recently started the actual full scope of the nursing component to this. So as mentioned, the wound care only came online in February, and immunizations only started last week. So really the intent of extending the pilot was just to see now and that fuller ability to provide nursing services through this partnership and the outreach model, and then be able to reevaluate to say, you know, what has the benefit or change been when we're able to do that more full scope nursing offering and to this slightly larger area that we have been noticing where clients are. I'd say, you know, in the past, the nurses have been going, you know, ad hoc to those areas anyway, and just seeing that many of the clients we were trying to reach are in those areas. I think in terms of the future state, I don't want to presuppose what the 18-month evaluation will say. I mean, I think certainly we've seen already a lot of benefit in terms of this partnership. It's a bit of a novel approach, and I think we've heard from the deputants as to what's there. I think we would really, I think, want to see, is it sufficiently different than other types of outreach that we already have? Certainly, we know that there are many different types of outreach happening within the city. We know that there's sort of expansion of other services within the city. How is this type of service best coordinated in vis-a-vis those other services, and is the need there? So I think that's where we'll be really focusing the attention of the future survey if this is extended.
Do you think thank you, and at that 18-month part, do you think that part of that conversation will also be if there's anywhere else in the city that could also benefit from the service? Is that something that you're exploring or not at this time?
I think the focus of the evaluation would be on the ability to serve within this current zone. I think we'll have to see if we're going to put into scope the expansion. I mean, certainly we have funded this pilot project through cost share dollars. I think the other variable between now and when we bring forward that evaluation would be to see what our mandate is in the forthcoming update to the Ontario Public Health Standards, and their ability to continue this type of outreach work, and really what is the nature that we might need to focus in on. So certainly right now, the current public health standards has a heavy focus on outreach, making sure we're supporting people who are using substances, doing this kind of nursing work in the community. But I think would be, if there's any other direction from the province as to what we're funded for, and what our current fiscal picture would be at that time as to whether we're able to look at an alternative option.
Correct. Thank you.
Thank you. Councillor Bravo.
Thank you, Chair. I simply had a question about the after-hours care or case management. My understanding is this program runs during the day, but the people who you might see and whose cases you're carrying might have there might be an interaction after hours with other workers from streets to homes, or the multidisciplinary outreach teams, or Toronto Community Crisis Service. Will part of the evaluation look at whether that handover is happening adequately? Because I ask because we get a lot of reports from the Toronto Shelter Division and to Economic Community Development Committee, and one of the areas of to watch is people not having to interact with multiple workers and have interactions that are then confusing, or that we don't have sort of the full picture of what that person's going through.
I will start, but I'm also going to turn it over to one of our directors maybe to answer that a bit more, and as well if our colleagues from TSS want to add to that. Certainly as part of the pilot now, the Toronto Public Health outreach workers are certainly coordinating with known others entities in there. I think absolutely that's going to need to be the case in the ad hoc area where we know many other services are in play in terms of interacting. The one-off interaction where we may be handing out food, I'm not so concerned about, but certainly when we're taking on clients for that case management, we are absolutely doing our due diligence to make sure that are they connected to any other services? Are they already receiving case management through other places? We don't want to duplicate that service. So making sure we're doing that connection there. But I think I'll turn to Dominic if he had any thoughts about where we could further evaluate that in the future evaluation.
Yeah, thank you.
Thank you, Dr. Murdy, and through the chair to you, Councillor. Yeah, so we are engaging in conversations with other city divisions serving this population. So those efforts will continue to ensure that there is coordination in terms of how we're serving these clients. I'd also note that this is a population that at times is challenging to locate and access, and sometimes those redundant or extra engagements is probably a better term are supportive in terms of ensuring that they're getting connected to the care and supports that they need. So yes, these conversations are ongoing and we'll continue to coordinate with our partners.
I guess what I really want to focus on is the handoff. Do we have a systemic way to hand off that information to the people that will take over after hours? Because in a 24-hour period, a person might have needs or be in crisis, et cetera, and it's, I think, it's a challenge for the people that are going to be operating, or on both sides, like having a systematic and systemic way to have a picture of people that you're interacting with, largely because I think a big part of this work is making a connection, building trust, connecting to services, getting people indoors, and other help they need, and eventually into housing or supportive housing. So what I want to know is that, will that be part of the evaluation, is sort of taking a good look at whether how that handoff is or isn't happening, and what needs to happen to make sure that it occurs. And if we're not building into the assessment the need to ensure that there's a complete picture of the individual, then we might not get a real sense of its effectiveness. And of course, sometimes it's also a value for money question around whether we're really serving that person, and I don't want to underestimate or devalue that there's a lot of interest during the day, operating, of thriving downtown, an important square, but the individual lives 24 hours a day. So just want to be really clear on that, and I don't know if we need a motion to that effect.
I mean, certainly I think our intent would be that how are we best utilizing this resource and how that fits within milieu. So, I mean, we can definitely commit to having that in the evaluation as this now is and being embedded to make sure. We do have after hours, we have evening services outreach as well, but really evaluating that handoff and connection. I know we have 20 seconds, but I don't know if I would just turn it to Gord from TSSS if you want to speak to anything about larger coordination efforts.
Yeah, thanks. And to you, Chair, there's more work to do here. There's more work to better coordinate and integrate the various teams across the city in various geographic areas, and to make sure that the service delivery is seamless, so that regardless of sort of who the individual interacts with, that they are getting a seamless case management plan and support. So I think there's more work to be done here, and certainly we've got council direction to undertake this integrated work. And so that's certainly at the forefront of our conversations currently.
Thank you.
Okay, thank you. Any other questions for staff? Go ahead, Director Midori.
Thank you so much. My one question is just sort of building on the previous questions, but is around the extent to which we're connecting folks to culturally grounded, to relevant supports. I think the report noted that the disproportionate impact of homelessness on First Nations and Métis folks, on Black folks, on 2S LGBTQ+. So I'm curious the extent to which the wraparound services, the navigation support is connected to sort of like mainstream system pieces, and the extent to which we're connecting into those other organizations and supports that exist tailored for specific folks.
To the chair, we have been routinely asking as part of the core program about Indigenous status to ask if, as we're referring clients to other services, is that, a service that they would like to be connected to or interested in. Only more recently, we've started having that data captured more systematically within our data system to have a better sense. We did do kind of a point in time survey of just 77 clients to look at that data as to what was the racial and Indigenous status of clients that we were serving. And I'm just trying to look for that number that we had in terms of the proportion. Certainly a number we're identifying as Indigenous, and you're benefiting from the referral to those culturally specific resources when that was identified. I think we have heard certainly from other service providers in the community that this is, that's an important connection that we need to continue to make as well. Dominic, you want to have that number if you have it handy?
Yeah, when we did the survey, 35% of respondents of the clients that we engaged identified as Indigenous. Yeah.
And just a follow-up, that I think it's absolutely important for First Nations and Métis. There's also likely other populations, right, that would be important for as well. And I just wonder how that could be integrated also into the pilot. Yeah. That'd be great to think about.
Is there a question here, or we're good? A comment? Okay. All right. No worries. Any other questions of staff? I do have one myself. So the Financial District BIA has requested that the core team also cover Union Station. Can you speak to perhaps the services that the core team already provides in the Union Station? Or I know it's not listed in the new boundaries, but perhaps you can speak to the work that they do there.
Thank you, Chair. So it is not part of our primary zone, but as we are interacting with clients, if we know that we've heard that they might be at Union Station, then certainly that's that ad hoc ability to go there to continue that engagement with a client that we've already been engaging with, who's generally more located within the primary zone. So we do have, we're not trying to solicit new clients within that area. We know that there are a number of individuals as well as a number of services within that area existing already. So we're not looking to duplicate the other types of services that are already there, and that we're looking to better coordinate, how we're making best use of the resources that are within that area. But certainly, if there is a client that we are already providing case management or support to, we would go there to support them.
Okay, that's good. I see Director Zhao has a motion specific to that, which is fine. I do have another question, though. So I know that the core team is first of its kind in the world, I think I was told by someone. I'd like to maybe hear from Toronto Police as to what they're hearing on the ground and how people are interacting with the police and the nurse, in that we know that sometimes the most marginalized and the police service now is, see eye to eye. So how has the engagement been so far?
So this has been a journey, probably years in the work, consultation, trying to bring partnership. So we're talking about mental health being health and should be health-led, and our service trying to use a public health approach to that, and we understand that. So it's difficult to say we're coming in to assist, right, in outreach for mental health when we also should be stepping back. So it's been a very difficult conversation, but I think there's also always going to be a time where the police might be needed, but not in this case. I think you also can't, we are transitioning. Though I think the whole world is transitioning on how we respond to mental health. And so there's going to be a lot of time where we're assisting each other, we're supporting each other as we find a new path and a new way to assist our community in all the ways that they need. Right? So I think this is unique. And I don't know what the end of the 18-month, if receive that extension will do, but when you hear and you're walking, and it's difficult to really measure anecdotal when someone says, like, the core team is my new family, right? Because they're taking the time, they're there. When have the police been able to really not be tied to 911, not be tied to actually have that time and ability to partner with medical professionals to do that actual outreach and to build trust? And that trust, comes in on foot but leaves on horseback. So, and we know that, and we see that all the time. So we know that it takes that time to be there, to be present, to be visible, and to partner, know when to lead, know when to follow, right? And I think hopefully something amazing grows out of it, but I think that we're providing a service to people who didn't have that service before. And it's unique because we are bringing primary care to people who don't have access to it, who don't have cell phones to follow up to know is it Monday, when's my next appointment with a doctor? So to have this kind of support and to figure out what we do next has been interesting. And I think when we put out the job call for police officers who want to apply, you are going to get very specific people who want to do this type of work. Right? So we had a social worker who's become a police officer, a new police officer, and he is chomping at the bit to come and work on the team, but he has to do his recruiting time, even though he's further into his career, but we're giving him an opportunity to come for 3 months because there are people who, we wear many hats, right? So it's just happy to see that we're working together. There are opportunities for improvement, but we're in transition, and I think what we're doing is unique and a little difficult, but it's impactful.
So what adjustments have you had to make from the start of the program to now? Because, because it's so new, I'm sure there's been some steep learning curves, right? So you'd have to adjust somewhat. So what adjustments have you made or have had to make?
So I think this will be really a Toronto Public Health because it's a lead, even though it's a partnership. I think from TPS, it's adjusting hours. So, not that it's right, but we pivot very quickly. We're here, we're able, where do you need us? And understanding that, it takes time, that our partnership is important to build all of this. So I think the only thing we've really adjusted is like the time, right? To ensure, okay, we're evaluating this. So are we required after 10 o'clock at night still, right? Or do we have to be shifting like the times and the schedules, et cetera? So I think that's probably one of the biggest adjustments and learning to work together. right? We have our training on de-escalation, on trauma-informed care, but it's not the training that obviously Toronto Public Health would get. So that cross-training, that developing that, the changing the roles of the nurses, adding responsibilities to them, and having to pivot, because we had the closure of the sites right when we were almost getting ready to launch. So yeah, I think the adjustments haven't been impactful enough to impact the clients, but I think Toronto Public Health should probably lead some of the adjustments that they've had to make, which is a lot more.
So to that, then, to public health, what adjustments have you had to make, Dominic, in the program?
Yeah, thank you. Thank you for the question, Mr. Chair. So certainly, building on what Chief Superintendent Skinner has said, we've made some logistic and operational adjustments in terms of our scheduling. We see a lot of clients during, regular business hours when people are sheltered often at night or found shelter spaces. There's a reduced need there. So we have tweaked that and allowed for more administrative and back office functions later in the evening. As Dr. Murdy mentioned earlier, we've done additional work to stand up the wound care, the immunization, those nursing functions. And moving forward, we've seen some opportunities in respect of, trying to locate some, space in which to see clients for the ongoing case management. So we're going to continue exploring these, and certainly, over the next 18 months as we roll out the nursing functions in greater, we'll be looking at those in greater detail to see what additional tweaks we might need to make.
Thank you. Need a motion to extend. Director Chandra-Ballin, all those in favor? Opposed? Carried. Thank you. Any other questions to be asked on this item? No? Let's go to speakers. Any speakers on the item? I just want to say that, it's been a great program, a great team that's leading this program. I've been here from the inception of this to today, and I've seen the great work that's been done firsthand. Last year, I went to a community barbecue with the clients they serve, as well with Toronto Public Health and Toronto Police. It was a great time. Everybody was happy. So we've really come a long way, and I'm so really excited to see what the next 18 months will provide. And again, it's extraordinary that they have actually engaged so many people. And I, being the councillor in Toronto Centre, even speaking to the merchants and just people generally, and the Downtown Young BIA folks, they have nothing but praises for this program. So it is doing what it's intended to do and beyond. So thank you to all those who make this a success, Toronto Police in particular, Toronto Public Health, and all our community partners. And with that, I'm going to ask Director Zhao to speak, because she has a motion.
Yes, so I added 2 amendments to the motion. I'm not sure if you wanted to put it up on the screen for others to view.
There it is.
And so it's been very clear from the speakers on this item that the core pilot program has been very successful, especially at managing the intersection of safety of the individuals who move and work around the downtown Yonge and Dundas Square area. And based on the letter submitted by the NAIOP Greater Toronto, Financial District BIA, Waterfront BIA, and Toronto Downtown West BIA, they strongly encouraged this program be expanded, or to include the expansion of Union Station, which also is a very populated area and is as a place for individuals who are experiencing homelessness to stay, especially during the cold winters. So my motion is just to recommend for the primary service area boundaries to explicitly include Union Station, and also for the medical officer of health to engage with some of these key stakeholders in how we can provide the same level of benefit that we do for the Downtown Young BIA as well.
Okay. Any questions for the mover of the amendment? Go ahead, Councillor Bravo.
I'm just wondering if there's been any conversations with other divisions involved in potentially in these areas with the Toronto Shelter Services and Supports Division, just in advance, if we're in terms of how plans to do like integrated work that we've described are maybe underway? Is that already happened? Okay, I see yes from the thank you.
Perhaps you want to speak to this, Gord?
Yeah, I mean, just to say that, you know, there is planning underway currently between Toronto Public Health, Social Development, ourselves, core team, Toronto Community Crisis, and Streets to Homes about how we might work in a more integrated way, and specifically in places like Union Station. So that work is underway, and we'd be happy to report back at a future meeting on where we're at.
So this impetus is really beyond what the BIAs are requesting, which is a very legitimate voice here, but it has to do with our social service planning and our kind of case management approach to do something really intentional. Great, thank you.
Okay. All right. And so we're okay with this amendment that's being brought forth? Okay. Again, in my question to staff earlier, I did ask if the core team actually went to Union Station, and they said that they do, right? But not for any new cases, but for they engage their clients that they're engaging with. But that's fine. Seeing no other speakers?
I'll just speak quickly to say that I thank you for the emotion, Director Zhao, and I think we have a really good opportunity here to try really intentional ways to resolve some of the questions that I had and that Director Matter had about who should interact, when they should interact, how they should interact, how we're gathering the data about the people, not just about ourselves in terms of the services that we deliver, but about how the impact is on the individuals and what, how do people move through these areas, et cetera, and to make it very outcome focused. So I appreciate the motion. I'll be supporting that. Thank you.
Okay, thank you. We'll put the motion on the screen by Director Zhao. Okay, all those in favor? Opposed, carried. Item is amended. All those in favor? Opposed, carried. Thank you. All righty. We're moving on to item. Where am I? Why is my number 8? Okay. So 2025 performance appraisal, medical health. There was one speaker on the item. It was Brooke Coatsworth. Is Brooke Coatsworth there? He wasn't there earlier. Is he online? No? Okay. Seeing no other speakers, anyone wants to speak to this item or ask questions? Seeing none, I'll move it. All those in favor? Opposed? Carried. The next item. Gina, what's the next item? A lot going on in front of me right now. The next item is my letter in response to Provincial Defunding of Consumption and Treatment Services. There is one speaker on the item. Who's the speaker? Haley Thompson, are you here? Online? Okay.
Hi, everyone. I just want to make sure that you can hear me.
I can hear you. Go ahead.
Great. Thank you. Good morning, good afternoon. My name is Haley Thompson, and I'm the Managing Director of Toronto's Drug Checking Service and our provincial expansion effort, Ontario's Drug Checking Community. I want to thank you for the opportunity to speak today, and particularly Chair Moyse and Dr. Murty. I'd like to thank you for highlighting the importance of our service and its findings on the unregulated drug supply, and for calling on the Ministry of Health and Health Canada to ensure our program remains available as a critical service service for people who actively use drugs. I also want to acknowledge that without the donation of samples from people who use drugs, in order to make the most informed health decisions, we are not able to provide the near real-time information on the unregulated drug supply that we do that informs evidence-based responses to the ongoing toxic drug supply crisis, which includes prevention, harm reduction, treatment and recovery, and community safety efforts. And Councillor Bravo, I also appreciate your question regarding access to our service. While we are federally funded by Health Canada to prioritize people who are at highest risk of overdose, so primarily those using opioids, our service is available to any member of the public who uses drugs. And notably, approximately 30% of people who have accessed our service have never previously engaged with harm reduction services or other health services for people who use drugs. So since launching in October of 2019, we've checked 20,000 samples from Toronto's unregulated drug supply, and approximately 98% of those samples were collected at supervised consumption sites. When the Community Care and Recovery Act passed in December of 2024, we began seeing a drop in sample collection, and once the SCS sites closed, specifically South Riverdale, the Queen West site of Parkdale Queen West, the Works and Regent Park, we saw approximately a 50% reduction in sample volumes. We are deeply concerned about the impact that these further closures or potential closures of Moss Park and Fred Victor will have, obviously, on the community and people who use drugs, as well as our ability to effectively monitor the unregulated drug supply. For those who may not be aware of our program, we are a national leader and a primary source of timely, comprehensive data on Canada's unregulated drug supply. And we know that things have significantly worsened since launching our service. The unregulated fentanyl supply in particular is increasingly volatile and contaminated. And we know that the risk of both fatal and non-fatal drug poisonings is real, ongoing, and cannot be overstated. Services tailored to people who actively use drugs, fentanyl and opioids in particular, have never been more critical. And we know that organizations like Toronto Public Health rely on our information to inform public health alerts. And also our data is also embedded in the Toronto Opioid Overdose System data dashboard. So again, just acknowledging the critical source of information that our service provides and helps to inform Toronto Public Health. Although our program is federally funded until the end of 2027 for now, the March 13th decision to end funding for Ontario's consumption and treatment services will inevitably affect the effectiveness of our current model. We are actively planning a transition. However, we don't have funding allocated to support that shift. But despite these challenges, our very tiny team is committed to maintaining service access and supporting and providing real-time publicly information on the unregulated drug supply. That commitment is unwavering. So I just want to thank Chair Moyse for putting this letter forward. And we appreciate Toronto Public Health's ongoing advocacy and collaboration. And we welcome any direct or in-kind support to help ensure the continued accessibility of our program and supervised consumption sites across the city, particularly if funding is not reinstated by the province. So thank you again.
Thank you so much for your deputation. Any questions for the deputant? Seeing none. You've covered a lot in your deputation here. Thank you. Any questions on this item? We've been kind of talking about it throughout this meeting, so I don't feel the need to ask any further questions. Any speakers on this item? So I'll just speak to it briefly, very briefly. So as the deputant mentioned, and as we've spoken about this throughout, is that we know that the province is ending the funding for the existing SCS sites, which will have and continues to have a profound negative impact on those who are most marginalized. And even though many people some people who come here and depute about supervised consumption sites, they just talk about one of the things that the service that's provided there, right, is harm reduction. But there's so much more that takes place in those facilities. And I have to say that, I've had the privilege of going into most of them and speaking to the staff and speaking to the clients and seeing the real work that's taking place, right? Be it, for example, housing referrals, mental health treatment, the wound care, women's care, and all those things. And again, referring people to long-term addiction facilities like detox and treatment and elsewhere. And it's also a place where people gather for community. You don't see that. Like when I went to the Moss Park SCS site, they actually had a couch and an area where people actually sat down and interact, right? And, because again, when you're on the street, there's really a lot of unhealthy relationships. And having a safe space to actually talk to people that experience the same things that you are and having to speak to a professional, that actually goes a long way. And that trust is built over time. It doesn't take place in one meeting. It takes place over, sometimes months, sometimes years. And I think, with the current SCS sites, we've seen that, especially in Moss Park and other areas. And I know that since some of the services have closed lately, as of the last year, the existing sites have seen a major increase at their doorsteps, Street Health being one of them, as well as the Moss Park SCS site. And I know the staff are feeling burnt out and overworked. And I know that, our own team at Toronto Shelter Support Services have tried to help in the best way they can just to support the staff that are there now. Because again, we need to make sure that everyone, not just the clients that are, in a good place, but also the staff who supports them. Frontline work is hard. I used to do it for many, many years. I can tell you that it's those who do it, they deserve an award and our thanks and our praise each and every day. So one of the things that was also mentioned too is that, and we touched on it a little bit, is that those who suffer from addictions, usually, their majority are Indigenous and racialized and equity-seeking populations. And again, when we take those services away, what we're saying to those who are most marginalized or in need, right? You don't care, you don't matter. And that is not something that I would support and even tolerate, not only as chair of public health, but just, a decent human being who lives in the city. These people are part of our communities, and we need to make sure that they are well taken care of. Another issue that's been talked about too is the drug checking samples, and it's through the SCS sites that we actually check the drugs. If we actually don't have SCS sites, the drugs are being checked, and we know, what's in the drugs continues to change and evolve. For example, horse tranquilizers. We know that naloxone doesn't work with these things in it, and so we're putting people at risk. And we're also putting our staff at risk, be it fire, police, paramedic, when they go and attend and support those people, right? So, we need to give everyone the tools that they need to make sure that, people are well supported, not just those that we are receiving care, but those who are providing the care as well. And lastly, in my letter, I want to also have the board endorse the letter from the Canadian Drug Policy Coalition and Drug Strategy Network of Ontario and the HIV Legal Network, urging the province to reconsider their decision to defund the provincially funded supervised consumption sites. So that's the gist of the letter, and I hope that we can get full support from this board, and I do hope that the province will listen to a degree, and at the very least, as I've mentioned, if they cannot continue to fund the SCS sites, at least provide funding for the services that is in place to support them in other ways. So with that, I will move on and ask for a vote on the item. Can we put it on the screen? I assume there's no questions. Okay. All righty, all those in favor? Opposed? Carried. And that's moved. And that brings us to the end of our agenda. Thank you very much for participating. It was a great meeting, and thank you again to our new members for also being here as well. And we'll see you next time. Thank you. And thank you to staff and to the clerk's office. Thank you.
Thank you.